Good morning, everyone. If you'd grab your seats, we'll get started. Good morning, everyone. I am Dean Andre Cummings, the Dean of this fabulous law school, Widener Law Commonwealth, and it is my pleasure to welcome everyone to our 7th annual Widener University Commonwealth Law School Emergency Medical Services Law and Policy Symposium. Today we're going to be talking about legal pathways to EMS system sustainability, and this has become, in my tenure here, one of my favorite days of the year. Our very esteemed alum, Doug Wolfberg, and his firm, Page, Wolfberg & Worth, have been an important part of the fabric of our law school and an important part of the fabric of EMS services in the United States. What I have learned in the 18 months or so that I've been dean here at the law school is that EMS professionals are a critically important part of our country. They are a noble service profession, and I have a great amount of respect for those of you that are engaged in EMS services and for the contribution that you all make to our country and to folks that are in need. So here at Widener Law Commonwealth, we welcome conversations. Last year, our symposium was about civil rights in EMS services, and it was a cutting edge and critical day where we learned. I'd like to welcome everyone that's here in person and those joining us on Zoom for this important policy and law conversation and discussion. I'm grateful for Doug. Those of you that don't know this, we are now meeting in the Wolfberg courtroom. It used to be room A180. On February 20th, we'll be having a naming ceremony where we name this room after Doug Wolfberg. So I'm grateful to him. I'm grateful to all of you for being here. And this all germinated when Professor and former Dean Christian Johnson was at the helm of the law school. And so I'd like to introduce Dean Emeritus and current Commonwealth Professor Christian Johnson to take us into this day today. But welcome, we're delighted to have you, and we're so proud of what this event represents. Christian.
It's been such an extraordinary opportunity to be involved with this symposium over the past 7 years. It's hard to believe that this was, of course, came from Doug and his law firm. The idea to do this, and the law school is just extremely supportive. I was thinking about how important EMS services are. Last night, my daughter had a fire on her stove, malfunctions and some other issues, and everything turned out to be fine. They were able to put the fire out and everything went, but of course it could have been very serious. And it just really reinforced to me that we all take for granted that at the most vulnerable points in our lives, when we have heart attacks, medical issues, fires, violence, auto crashes, whatever it might be, that EMS is going to be there. That is just the assumption we all make, and we just assume that we call 911, that emergency medical personnel are going to show up and that they're going to be able to give us the kind of care and help we need when we're so vulnerable. And, it struck me as we've had these different themes over the years, just how society depends so much, yet gives so much lip service at times to supporting EMS and providing it with the resources, and again, the legal sustainability to make our system effective and to provide the help when we need it. And so it's just been extraordinary to have the chance to listen to the professionals and others that come here and talk about what those needs are, the important legislation and regulation and changes and support that our system needs. And we're honored as a law school to be a part of this process. I'd like to turn the time now to Doug Wolfberg. So thank you.
Good morning. Thank you, Dean Emeritus Johnson, Dean Cummings. A couple of other acknowledgments that I'd like to make here from the podium before we get started. First and foremost, probably in the back, being the Wizard of Oz, Brian Fernbaugh, our technical director, who this and every other program that's ever happened here at Widener Commonwealth Law School has made it work so seamlessly and so effectively. So thank you to Brian. I'd also like to acknowledge the sponsorship, I think since day one, since we've started this program, of the Ambulance Association of Pennsylvania. Their president, Gary Waters, is here, and we thank AAP. A few of our AAP board members are also here, and you'll be hearing from the legislative chair of AAP a little bit later when we talk about what's happening legislatively. So I'd also like to thank AAP. I'd also like to acknowledge, everyone that's here and everyone that's online. Just looking at the attendee list, we've got a kind of a who's who in EMS, both here in the room and attending online. So by mentioning a few people specifically, it's not to the exclusion of anyone else. But I do want to acknowledge that our state EMS medical director is here with us, Dr. Dan Bledsoe. Appreciate you being here. As well as the regional EMS director of the EMS region in South Central Pennsylvania, the Emergency Health Services Federation, Steve Lyle, who also will be retiring a little bit later this year in June. And Steve has been at the helm of this regional EMS council for a few decades, and has been a prior presenter at this symposium. And I want to acknowledge Steve's both his presence and his service and his impending retirement. It will be quite a change here. And get my clicker here. And I want to thank, first of all, Dean Cummings for continuing the law school's support of this program. And you couldn't tell from the humble way in which he introduced today's program, but Dean Cummings has been here 18 months and is the definition of a transformational leader of this law school. I open up LinkedIn, and he's somewhere in the United States raising the profile of the school, participating in events, engaging with alumni, and our school has reached unprecedented bar passage rates under his leadership. And just the way that Dean Cummings has already and is transforming this school is really remarkable. And I want to thank Dean Cummings for his continued support of this program and acknowledge his transformational leadership that has already occurred and that is still occurring and will occur into the future. I also want to thank, yes, by all means. I also want to thank Professor Dean Emeritus Christian Johnson and Corinna Wilson, who will be here. And Christian and Corinna and myself for 7 years now have sort of been the core little planning team for this event. And every year it's always fun when we get the band back together and talk about how we're going to do each year's program. We have quite a few people attending online and the crowd here in the room. So this isn't the largest EMS event that I think a lot of folks will attend, but it certainly is a labor of love, and one that this little core team has been shepherding now for 7 years. So I want to acknowledge them as well. I also want to just quickly acknowledge all of my colleagues from Page, Wolfberg, and Worth who are here seated around the room. Matt Zavatsky, who I'll introduce in a moment, Steve Johnson, Carrie Nace, an alumni of this school, Christy Malott, Scott Jockin, an alumni of this school, Matt Konya, an alumni of this school, and Dr. Donna York. Did I miss anybody from PWW? It's like, oh, Steve Worth, yeah, of course, seated over there, who I'll introduce a little bit. Oh, Ryan Stark, my partner, Ryan Stark, who are also here. So, gosh, and an alumni of this school, right? Matt and Ryan were both also students in my health law class, so they had to suffer through that. But in any event, so thank you to all of the folks at PWW for being here and for attending. A couple of quick announcements. If you are an attorney seeking continuing legal education, There is the CLE form. Make sure you get that, fill it out with, you know the drill, with time attended and all that kind of stuff, and then turn that in when you leave. If you are an EMS clinician today, and the hours are different because CLE hours do not accredit keynote speeches, but EMS does. So today's program is eligible for 6 hours of EMS CLE. Under the other category, if you are a Pennsylvania licensed EMS clinician, if you are attending here in person, there's a sign-in sheet for EMS Con Ed. If you are attending virtually, this is in your handout materials, but you can email Matt Konya at pwwemslaw.com, mkonya, and provide this basic information, and he will assist you if you are a Pennsylvania certified EMS clinician. If you are out of state, you will need to submit this to your Con Ed accreditation agency, and if Matt can assist you in that process, please feel free to reach out to him. This year's theme, as you heard, is legal pathways to EMS system sustainability. So we are going to be talking about really EMS transformation, and this is a subject that's kind of near and dear to all of our hearts. And in a minute, I'll introduce Matt Zawadzki, our keynote speaker, who will kind of set the tone for what EMS transformation looks like. And before the symposium started today, I was talking with Steve Lyle, and we were both, as we're now officially EMS dinosaurs, we talk about being sort of on the back nine of our careers in EMS, and how for the first, maybe 20 or 30 of the years we've been in EMS, things really didn't change. The response model was monolithic. Somebody called 911, EMS responded, and everybody got transported to a hospital emergency department. That approach is not only not patient-centered, but it's not economically sustainable. And that's really the idea behind what we're going to be talking about today. That the majority, statistically, we know that most people who seek EMS have low acuity conditions for which they're not going to die or suffer negative health outcomes if they don't get an immediate response and an immediate transport to an emergency room. So there are different modalities, different ways that we can operate to not only be patient-centered, but to be economically sustainable. And we'll talk about, some of those themes as we go through the day. So that is the kind of guiding theme here. In a minute, I will introduce our keynote speaker, who will talk about the evidence-based case for EMS system transformation. I will then talk about legal barriers to that kind of transformation. We're going to look at some specific laws in a few states around the country that are sort of emblematic of the legal blocks that we could encounter when we try to do this type of transformation. We will have a box lunch, just a short, everybody will grab lunch, come back in, we'll keep going. Then my partner and colleague, Steve Worth, is going to talk about the people side of change, because as we talk about this sort of fundamental transformation, it's important that we not forget that our human resources are at the center of all of this. We will then be joined by the legislative chair of the Ambulance Association and the panel of Matt, Steve, and myself, who will talk about both state and federal, both legislative developments and recent laws that we all sort of need to be aware of. Then we'll have some closing thoughts. So with all of that, let me introduce our keynote speaker. So for about 18 months now, I have had the privilege of waking up every day and seeing emails, because he's always up before I am, even though he's an hour behind living in Texas, and seeing my inbox full of emails from this guy and going, oh, we work together, we're colleagues. So I get to work with this transformational EMS leader, and it is an honor and a privilege. Matt Zawadzki is an EMS mobile healthcare consultant with PWW Advisory Group. That is our consulting company. He has over 40 years of experience in EMS as a field provider and in EMS system administration. Prior to joining us at PWW, Matt was the Chief Transformation Officer, kind of a perfect title to be kicking off the day here, for MedStar Mobile Healthcare, the public utility model EMS system in Fort Worth, Texas. In that role, Matt assisted with numerous EMS system transformations such as mobile integrated healthcare, community paramedicine, 911 nurse triage, tiered deployment models, alternate response, and alternate disposition programs. Some of that's linguistic. Matt will talk about what all those things mean in his presentation. Matt is also the co-author of 2 recent joint industry position statements on EMS performance metrics and the reduction of light and siren responses. Matt holds a master's degree in healthcare administration and is still a practicing EMS clinician.
We're all practicing.
Yeah, we're never getting good at it, but we're still practicing. So please welcome our keynote speaker, Matt Zawadzki.
Thanks, Doug. Okay, and also what Doug didn't mention is I also tend to be a little bit OCD, and I'm noticing that there's an OCD issue with the room. So I'm going to have to ask everybody over here to move over here. Is that okay? We don't handle change well, do we? We like the things that we like. Couple of questions for the folks in the room and online, and Doug is monitoring the chat. Raise your hand if you have been in EMS, and you're going to always see me say EMS with air quotes, have been in EMS longer than 20 years. Okay, almost everybody in the room, and I'm going to guess most of the people online. So people online, raise your hands also. This is all recorded, so we're going to use this perhaps at some point in the near future. But would you say that things have changed in how we deliver service? I was just reading on the plane here yesterday a book written by Marty McCrary, one of Steve Worth's fans, or vice versa, I should say. And he was talking about, and for those of you that don't know, Marty McCrary is the current FDA commissioner. He started his medical career, by and large, as an EMT here in Pennsylvania. He was a volunteer EMT at the age of 16, and he says in his book, the most cool thing that he did as an EMT at the age of 16 was drive an ambulance licensed siren. And that was the coolest thing ever, and that was one of the main reasons why he thought being an EMT was cool. In fact, he and his 16-year-old partner thought it was so cool to operate the ambulance licensed siren and watch people have to move out of the way that he admitted in the book that he would often activate the licensed siren on nursing home transfers just to get cars to move out of the way. It's in the book. But that's sort of an MO that 40 years ago was standard, and I would argue today in most systems is still happening. And we're going to talk about some of that. So what we're going to do for the next hour or so is try and dispel some common myths about EMS. Most of you are in EMS. This could be a hard lesson for you, but the evidence will show what some of those myths are. We're going to talk briefly about the staffing and economic crisis in EMS. They are linked. One of the reasons why we have trouble with staffing is because we can't pay people what they're worth, and certainly not what they think they're worth. We're going to identify what are the barriers, and Doug's going to talk about the legal barriers, but we're going to talk about sort of the other barriers to prevent these, that are preventing some of these changes from taking place to improve clinical proficiency, operational effectiveness, and economic sustainability. We use those 3 terms a lot in the work that we do across the country. Most importantly, we're going to learn why dads and granddads should not be left alone with children. Looking in the audience, I'm going to guess that some of you have grandchildren. Raise your hand if you have grandchildren. Okay, and online, raise your hand if you have grandchildren. Would everyone agree that grandchildren are way better than children? For obvious reasons, right? Because you can liquor them up. When they start to smell, you just give them back, right? And our role is to corrupt them. These are 2 shirts that I have in my closet that were given to me by my kids. They call me Grandpa because partner in crime makes me sound like a bad influence. It is absolutely true. And Grandpa, the man, the myth, the bad influence. There's a gentleman who has started a series of social media postings with his kids photoshopped doing crazy things. How it started, so I've read, is that he works at home and his wife does not. The mother of his kids does not. And she would text constantly, how are the kids, how are the kids? Because obviously she did not trust him alone with the children. He became so frustrated with the constant questions that he started sending pictures back to her of what they were currently doing. And you can follow them on Facebook, Instagram. It is hilarious. But we're going to show some of those pictures throughout the presentation this morning just to keep it relatively light. So here's one. I can't say that we haven't tried that at home. This is what happens when we go to the zoo with our grandchildren. We're napping and they're over talking to the cougars, right? So you got to be very careful. All right, so for folks in the room, call out, and folks online, put into the chat, what are some of the most common myths about our profession? Just call them out. Speed matters. What else? If you're going to the ER, you have to go by ambulance, right? No, you get into the ER. Oh, yeah, going into the arriving at the ER by ambulance puts you in the express lane to a comfortable bed and a hot meal, right? What other myths? Always available. EMS is always available, always able to respond. We'll be there within minutes, and well, we're going to go back to that in a second, but Carrie's spot on.
Local communities pay all the tax support they need.
Yeah, we're flush with funding, right? I mean, oh my gosh, we make all this money because, you read in the newspaper, people are getting $7,000 ambulance bills, so what the hell are we doing with all that money, and why do we need tax support, right? Medicare covers everything, all rides to the emergency department, and they reimburse us at our cost, right? That's pretty standard. Yeah, it's a common myth. How about one last that we haven't really covered, about staffing of EMS response units? What's a common myth? Every response needs a paramedic. And the more paramedics that you have in your system, the better the system, right? So if you have 10 paramedics versus 2 paramedics, then your system is better. I think we've covered all of these. Oh, EMS response volume is largely unpredictable. I heard that yesterday from a community member on the West Coast who said, well, we have to staff this way because EMS response volume is unpredictable. I said, really? Send me your last year's CAD report and I will show you that is not true because EMS response volume is actually very predictable. So let's talk about this time sensitivity thing and the acuity of the calls. So when I was at MedStar, we looked at a response volume change over time, over a decade, as a percentage of our call volume. We wanted to see what types of calls were increasing and what types of calls were decreasing as a percentage of our call volume. What we found is that the low acuity responses were the responses that were growing as a percentage of our call volume. Now, call volume in general was going up, but when you do the math and say, okay, from a percentage perspective, the low acuity calls were increasing, the high acuity calls were decreasing because of all sorts of reasons. But, for example, when you look at motor vehicle crashes, I'm from Texas, and we have a ton of rollover crashes. It's amazing to me how many rollover crashes we have, until I figured out there's a very legitimate reason why we have so many rollover crashes. If you look at most vehicles in Texas, they have a very high center of gravity. And it is very windy there. And they have these huge Texas and Confederate flags that they put on the back of their pickup trucks that causes the trucks to tip over. But even rollover crashes, very rarely do we take someone to the hospital because there are 1,500 airbags and seat belts and all sorts of things, and people don't get seriously injured in a lot of those crashes. So we see that a lot of the responses that we've seen this nationally, the low acuity calls are the ones that are increasing. When we were investigating in Fort Worth, going to a tiered deployment system, and you can't see it, and Doug always criticizes me for putting up the Matt Zavodsky eye charts, but you'll see this in the handouts. This is an actual data analysis that we did of over 453,000 patient contacts. 1.7% of our patient contacts in the Fort Worth EMS system were potentially life-threatening conditions that received a potentially life-saving intervention. We just finished a study in West Virginia, and to highlight this point, we looked at what percentage of the patients that the crews were treating received advanced life support care. And as you can see, about 33% of the patients received advanced life support care, 60% of the patients received basic life support care. That statistic has been, and close to that, has been reiterated several times in things like the Ground Ambulance Data Collection System report and other reports. So overall, about 30 to 40% of the patients receive advanced life support care. In that system, what was interesting is there's chicken shit ALS care, right? And I would say that chicken shit ALS care is monitor an IV just because you can. Not necessarily because the patient needs a drug or whatever. So in one of our projects, we looked at what percentage of patients actually receive a medication besides oxygen. And in the analysis that we do, and we just finished another one we'll talk about in a second, only 17% of the patients in that system received a drug. Of that, half of the drugs that were administered are eligible to be administered by a BLS EMT. So in terms of true paramedic level ALS medication that patients received, 9% of their patients received a drug that a paramedic had to administer. But yet they've been struggling for years with staffing because they endeavored to put a paramedic on every ambulance. And because of that, they could only get an 85% scheduling efficiency, meaning that, hey, we don't have a paramedic to put on the ambulance, so we're not going to staff it, instead of putting 2 EMTs on ambulances and putting them out into the street. That concept that we need all ALS is really not true, because the vast majority of patients that we treat in the field, are treated through BLS. Notice that in that system, they do 1 endotracheal intubation every 2 days. And from an intubation perspective, what does the research show that paramedics need to, how many intubations does a paramedic need to do a year in order to maintain good proficiency according to virtually every study? 10 per year on real dead people, not high fidelity mannequins, not all the crazy things. And if paramedics are not doing 10 live, quote unquote, live intubations a year, they're going to be very good at it. And think about that from a other critical skill perspective. Do you want the paramedic who initiates ALS care very little, and we'll use intubation, for example. If you're going to have a cardiac procedure, do you want the cardiologist who does 10 procedures a month, or do you want the one that does 10 procedures a week? So we need to really think about that as we go on. Another study that we're doing right now here in this state shows that, again, about 30%, 25, 26% of the patients that they treat get an IV. Okay, that's ALS care. So essentially, when you look at it overall, any one of these procedures, about 43% of their patient contacts is some type of ALS care administered, and quite frankly, the majority of the time, it's that chicken shit ALS, the IV and monitor just because you can. And when you look at the medications administered, again, in that system, the majority of medications administered are administered by paramedics, because Pennsylvania's protocols, Dr. Bledsoe, are a little bit more restrictive than West Virginia's. West Virginia allows EMTs to do a lot more. But again, very few of their patient contacts, 1.3 per day, receive ALS care. Sir?
Did you assess for missed opportunities?
What do you mean by missed opportunities? You mean a patient?
You see what was already performed. What about the
We did not do that analysis. This is strictly based on documentation. But I can tell you that in both of those scenarios, there was a paramedic on every one of those calls. Every one of those calls. So it wasn't a missed opportunity because there was no ALS provider. The ALS provider was on the call. It just wasn't administered. You could, and I would leave that up to the medical directors to monitor that and make sure that that's not happening. And I trust the medical directors in those systems to do that. So, but good question.
Matt, sorry, could you just question
Oh,
sparked your comment?
yes.
For the online folks.
Question was, could there be some missed opportunities here where ALS care could have been administered, but it wasn't because the ALS provider on scene didn't recognize the patient needed ALS care? The response, as you saw, was that's up to the local medical director and the folks to do their QA process, and we trust them to make sure that they're not missing those opportunities. So, Great question, though.
Our future questions will come around.
Awesome. This concept of critical interventions has been studied several times, and one of the most notable studies to date has been a study that was done that looked at over 6 million patient care records and found that 6.9% of the patients received a potentially life-saving intervention. And many of you in the room, I can see you doing it, you're nodding your head, saying, yep, we agree with that because I've been in the field, and that's really what the percentage is. Okay, before we move to the next topic, why grandpas should not be left alone with kids. For those of you that can't see it, the book that he's reading to the children is The 10 Bloodiest Murder Cases. So imagine your mom, right, and you're getting these pictures from your husband about, so he does explain that after a while she just stopped asking, right, because there are times when, and that was the eventual goal. Now, had I known that my cozy coop could have done this, and admit it, how many people are thinking, how could I do that at home? So when you get home and you go see the grandkids, build the ramp, we're good to go. Just make sure you got the real human underneath there. It's important. All right, response times. This is a soapbox that many of us have been on for a long time, and finally, maybe, getting some people to agree that response times are a horrible way to measure the performance of an EMS system. So where did this concept of the need for speed come from? It essentially is grounded in a research study that was done that showed if someone goes into cardiac arrest in the field, if you could have someone on scene patient side within 4 minutes to initiate CPR, and if you could have definitive care at patient side within 8 minutes, and definitive care was defined as defibrillator, the patient's chances for survival doubled. When was this study done? Some of you know the answer, so you can go ahead and call it out. This study was done in 1979. In 1979, what was the only type of field practitioner who could defibrillate someone? Paramedic. Today, who can defibrillate you? Girl Scouts, right? I mean, anybody can defibrillate you. So that's sort of where all this came from. Now, what's fascinating is that they focused on the 8-minute definitive care, but we have conveniently not focused on the 4 minutes CPR. How many people in the room or online are willing to say in their system, you have built an EMS system that will put a trained responder at patient side to do chest compressions within 4 minutes of the call ringing in the 911 center? But yet, the study shows it's the most important factor. How come we're not doing that? Because it's hard. But yet the evidence shows that matters. But we hang on to the 8 minutes like it's gospel. It's not anymore. 79 it was, not anymore. In your handout, you'll see these are all the studies that have been done that dispels the rumor of response times making a difference in patient outcomes. The bottom line is there are some calls, 5%, 6.9%, that require a fast response for a potentially life-saving intervention. For 80 to 90% of the other calls, the response time is not going to matter in the patient's outcome, and arguably, same-day service would probably be fine. But yet we have this expectation that we need to be there within 7, 8, 10, 11 minutes, whatever it is. What about expectation? We hear all the time from systems that say, well, patient expects us to be there within 10 minutes. Okay. Who gave the patient that expectation? We did. Based on flawed science, based on information that is not current, and based on competing for a contract, perhaps, or retaining a service area, because measuring response time is easy. Measuring chest compression fraction time on cardiac arrest patients is hard. Which one of those two things make a bigger difference in the patient's outcome? Exactly. So to dispel this objection, if you will, in our system in Fort Worth, because we were doing a bunch of these changes, we were blessed that we had 10 years of patient experience surveys done by an outside agency, and we took the responses to the survey in which the ambulance only responded to the call, no first responders, and we responded no lights and siren. There are about 13,000 of those responses. One of the questions on the survey was, did the ambulance arrive in a timely manner? Not, did the ambulance get there in 11.5 minutes? Not, did the ambulance get there in the expected time? On your perception, do you believe on a scale of 1 to 5 that the ambulance arrived in a timely manner? And what we found is that even with response times of 60 minutes, 1 hour response times, we were still getting scores of 4.8 to 5%. Because the crew is nice to the patient, we had a big focus on patient experience. If the crew's nice and the patient knows they called 911 with a low acuity call, the fact that someone came today is great for them, and by the way, we gave them a free ride to the hospital. So this concept of the patient expects it, we gave them that expectation, we can change that expectation. Thankfully, a number of national and international associations got together and discussed this concept of light and siren, time critical, all that sort of stuff. Responding lights and siren are dangerous. Puts the public at risk, puts our crews at risk, very rarely saves any significant amount of time, certainly not time that would make a difference in the patient's outcome. So these associations got together and wrote a position paper, and Doug mentioned it in the beginning, that basically tells communities, stop using response time as the measure, and by the way, based on all the research, many of which, by the way, have been culled and put into a meta-analysis by Dr. Doug Kupis from here in Pennsylvania in the NHTSA report that he did, 220 different citations that he has in that report that light and sirens kill people, doesn't save a whole lot of time, and are unnecessary. And then he's got a whole appendix about conspicuous, obvious ambulances. But you should take a look at that study, and I think part of it will be in some of the resources that you have here. But essentially, decreasing the use of lights and siren. The number of organizations that signed on to this position statement are there on the screen, and you'll see them in your handouts. These organizations, on any given day, will not agree on the color of the sky. But yet, they all got together to sign on to the fact that we need to stop responding to as many calls as we are lights and siren. It doesn't matter. It's dangerous. It hurts people. Okay? Similarly, we need to stop using response time as a measure of performance of the system. It could be a measure, but it should not necessarily be the measure. Because again, if you can get to a cardiac arrest in 8 minutes and perhaps have someone do chest compressions within 4 minutes, but your chest compression fraction is 70%, or you've put on a mechanical chest compression device, and within 4 minutes, like in most cases, the unmonitored mechanical chest compression device is now doing liver compressions. People are laughing because they know it's true, right? If we're not doing a good job with pain management, STEMI bundle compliance, stroke bundle compliance, trauma, on-scene times, we are unfairly evaluating the EMS system. I would much rather have a 10 to 12 minute response time to a cardiac arrest by the ambulance and faster response from first responders, and know that we're getting the AHA recommended 95% chest compression fraction, because that's going to make the bigger difference in patient care. I would rather know that, hey, I don't care what time you get to the STEMI case, as long as it's reasonable, but I want to know that 98% of the time you gave aspirin, nitro, 12 lead, transmitted, STEMI center. When we talk to chiefs of departments and other community members and they say, we've got a great EMS system because our average response time is 7 minutes. Okay? So what's your compliance with the STEMI bundle of care, according to NEMSQA? almost invariably the answer from the department chief, or in many cases the elected officials, is, what now? In Medic, Charlotte, North Carolina, has been really on the forefront of changing community expectations and saying, listen, response times, we're going to talk about it more in a minute, but they are very expensive. They're the #1 cost driver. And they did a study, and they actually implemented a process that said, hey, for low acuity 911 calls, our new goal is going to be 60 minutes. So when you call 911 with low acuity 911 call, our goal is to get to you within 60 minutes. They've recently, this past year, updated that protocol, and for some of those calls, their new goal is 90 minutes for 911 low acuity call. Sir. Oh, yep, microphone, sorry. Excuse me.
So just trying to compare Medic to what we see in Pennsylvania. Medic, if I'm not mistaken, they have their own dispatch center where 911 calls are routed to their dispatch center. Then they're able to determine the response from their own organization.
Correct.
Whereas we use PSAP centers here in Pennsylvania. So what can we say that would help us to try to be a driver for this type of success
Sure.
in our type
So
of system?
if you're, we were going to talk about it in a minute, but we'll talk about it now. These protocols and being able to change ALS, BLS, response times, et cetera, are predicated on the fact that you are doing the appropriate thing for your community and that your 911 center is doing emergency medical dispatch, pre-arrival instructions, call prioritization, and response mode prioritization based on national best practices. Now, if your community has not been able to grasp the value of doing evidence-based emergency medical dispatch, and you're doing the old style, press a button, get a peanut, we need an ambulance at First and Main, okay, we'll send an ambulance to First and Main, and you have no idea what you're going on, then these are going to be tough to do. Those are the unenlightened, and I'm going to make Doug real nervous here, the folks who are not bought in to an EMS system. They're bought into a archaic, transport-driven, everybody just needs to go to the emergency room, everything needs to go hot, just send the boo-boo bus to take everybody to the hospital. Those systems, and several of them here in the state, in the Commonwealth, are really no longer sustainable. And we get emails and phone calls every day from organizations saying, holy shit, they now want a $1.8 million subsidy to do what they've been doing for free for the last 10 years. What the hell? Okay, let's talk about system transformation. Sorry, got a little edgy there, Doug, if that's okay. Didn't want to get people upset. So one of the reasons that they do this was to save costs. They're a heavily subsidized system, and bottom line is, when they started this process, the first year, they went to 21,000 911 calls with a 60-minute arrival time. Guess how many response time complaints they received in that first year? 3. All from first response agencies. All 3. The medical director said, why were you there? Because you're not supposed to go on those calls. Well, they were at the station, or they were whatever, and that's fine. But the reason they got no complaints, or very few complaints, was when the caller said, hey, I've got blisters on my feet, the dispatcher, call taker said, okay, great, the call's important. We're going to send somebody to you. Our expected arrival is within an hour. If anything changes, please call us back. So what now is the patient's expectation of the response time? So if you get there in 45 minutes, you've exceeded their expectation. But you've set a realistic goal for getting there. All right, let's talk about this all ALS thing. Back in the 80s, Jack Stout, a healthcare economist, by the way, developed the concept of a public utility model system that I worked in for several years. The concept is the public owns the infrastructure, they contract the people from the private sector, and the private sector manages the resources, because the private sector generally manages resources more efficiently than the public sector. Worked in both, I can tell you that is absolutely true. Back when the first public utility model system was put into place, it was massed in Kansas City, dispatch centers looked like that. Perhaps some like that in Pennsylvania today, where they don't do EMD. And because of that, Jack said, hey, we should have a paramedic on every call, because if you're doing the push a button, get a peanut, we need an ambulance at First and Main, you have no idea what you're responding to, you probably should send a paramedic on every call. That's the way that first public utility model system was designed. It was also designed because at the time, you could get more fee-for-service reimbursement if you staffed a paramedic on every truck. But right after that system, that public utility model was put into place, the concept of emergency medical dispatch came out in the early 1980s. And today, and to date, internationally, every time the use of emergency medical dispatch, specifically MPDS, has been studied, has been compared to patient outcomes, have been compared to what EMS crews actually find in the field, when EMD is done in the right way, with quality assurance, physician-led, patient protocols, et cetera, the correlation between what the dispatcher identified as the complaint and the complaint the crew found on scene, amazingly accurate, in the high 90 percentile, if it's done correctly under the right environment. Similarly, there have been multiple studies that have shown the more paramedics that you have in your system, the worse the patient's outcomes. Why? Because the paramedics don't get to practice their skill and they don't do it well. Back to the concept, cardiologist treating your family member. All of these studies that you'll see have identified that the more paramedics you have in the system, the more skill dilution you have, the worse they're going to perform when they have to. Don't take our word for it. These are the studies. Large systems, small systems. Love this one. All the way back in 2003, Dr. David Pearce, who is the medical director for Houston Fire and the public health official for the city of Houston, and an EMS award winner, very innovative doc, they went from a single deployment system in 2003 in Houston to taking paramedics off the ambulances, putting them on a few squads, having BLS ambulances, a few ALS squads, and they proved that cardiac arrest survival, endotracheal intubation success rates, IV success rates, every clinical metric skyrocketed when they limited the number of paramedics. Imagine that. Why do you suppose that is? The paramedics are phenomenal. Real quick, if I were to ask, based on cardiac arrest outcomes, which is how we all measure the performance of our systems, what EMS system is the best in the country? Seattle Medic 1, right? King County. One of the hallmarks of the King County system is their ALS paramedic units only respond to echo calls. Every other type of call is given to a BLS contractor. And because the Medic 1 units respond on all the high acuity calls, they are kick-ass paramedics. And their performance shows. Now, there are all sorts of things that are unique about King County. You can't graduate high school without being certified in CPR. You can't renew your driver's license without being certified in CPR. In fact, they say that Seattle is the safest place to have a cardiac arrest, but it's the most dangerous place to sleep on a park bench, right? Because someone start doing chest compressions on you. The famous researcher, Bob Davis from USA Today, found this back in 2006 when he studied EMS systems and said, hey, those systems with more paramedics had worse patient outcomes, so why are we doing that? Excuse me. All the studies, all the research will be in your handout, so you can look at it for yourself. Don't take our word for it. This is just evidence. EMS response volume is largely unpredictable. Here are 4 studies that we've recently done that track response volume by time of day. The x-axis is the hour of the day. The y-axis is the response volume. Holy crap. Is there a pattern there? What are most people doing at 3:15 in the morning? Sleeping. What are most people doing at 5 o'clock in the afternoon on a weekday? Driving, crashing into each other, arriving home and finding the kids with the sniffles or grandma on the floor. EMS response volume is absolutely predictable. If you were to statically staff the same number of units 24/7 as indicated by this red line, half the time you're wasting money. Half the time you've got response time issues, level zeros, mutual aiding calls, losing revenue, having performance issues. That's just not good policy. And it's certainly not patient-centric care. Unfortunately, many EMS systems were based on a fire model where fire stations and fire staffing is built to protect property, not people. They are different. So you have to use a different model. So this is an analysis of, again, the MedStar system in Fort Worth, and many systems now are doing that, is you really tie resources to need as a way to be more financially sustainable. But it's not just how many, it's where. In many communities, you'll have a core city central and then suburbs. People move throughout the day. They leave their home, they go downtown to work, in the afternoon they go home, weekends they're home. You have to have or you should have a system that allows the resources to follow where the people are. You're not covering structures, you're covering people. So in many innovative systems, they will move resources around throughout the course of the day based on predicted call volume in that area. In the Fort Worth system, the urban core inside the loop, we put a ton of resources inside the loop during the day, very few outside the loop because all the people are inside the loop. 5 o'clock, we flip that because there's nobody downtown anymore. They're all in the suburbs. So you have to be nimble. That helps with that financial sustainability and that clinical proficiency. Why grandpa should not be left alone with the kids? I may or may not have been guilty of that one on the right more than once. In fact, I am really grateful that the knives that they gave us at breakfast this morning were plastic because I had to do this to get my bagel out. And thankfully, and I couldn't unplug it because the plug was under the table and that would have been too much work. But anyway, all patients who call 911 need to go to the hospital. This is the most recently published data from the Center for Disease Control that shows that 17.6% of patients arriving in the ER arrive by ambulance. Okay, that probably makes sense, right? Passes the sniff test. However, of those, only 44% are admitted to the hospital, meaning that 64% of the people that we schlepped to the emergency room are treated and treated from the ER. Holy crap, what could we do with that percentage of patients to treat them in place and not bring them to the emergency room? Anybody in the room participate in the CMS or online, participate in the CMS ET3 model? Yeah, hardly anybody. Why? Because it was like impossible to participate. You had to sign a 134-page contract of adhesion that you weren't allowed to change from CMS that required you to do HIPAA violations. A lot of people didn't want to do that. It was implemented during a pandemic. It was implemented at a time that we had to take patients to an alternate destination, but there were no alternate destinations willing to take ambulance patients. But for those organizations that did do treatment in place and get reimbursed for it, the patients loved it. The healthcare systems liked it because it decreased the utilization of the emergency room. There was one constituency group who wasn't very enthusiastic about ET3 or about treatment in place in general. Can anybody guess which constituency group that is? ER physicians. Why? Because it impacts their revenue. In fact, it was hilarious. During the March 2005 to 2025 MedPAC meeting, apparently MedPAC finally opened their eyes and somebody said, wait a minute, we only pay EMS if they transport to the hospital? And Steve, Doug, myself, others who were monitoring this online, were yelling at the computer screen, no kidding, Stunad. We've been telling you that's stupid for years. Because they said, well, why would we incentivize them to spend our money? That doesn't make any sense. And everybody on the commission spoke in favor of, yeah, we really need to pay them for the response. So why don't we consider changing the payment model? The one person who said, they're just EMTs and paramedics. They don't know which patients need to be seen in the emergency room or not. Those patients need to go to the hospital to be evaluated. Obviously, the patient thought they were having a medical emergency. They called 911. So that board member, that MedPAC member, was the one ER physician on the panel. Which kind of makes you question, what is the motivation here? So we could do a lot with those other patients. And we're going to talk about this concept of mobile integrated healthcare. A lot of folks know that, community paramedicine. I just want to make sure it's real clear that MIH is really an umbrella term which includes a bunch of different things. And perhaps even the 911 response and transport, appropriately so, to an emergency department. So the things that we're going to hear more about later today and that are happening across the country, 911 nurse triage, alternate response, alternate disposition, using nurse practitioners, community paramedics, and others to prevent 911 calls. It's a book written several years ago about EMS systems and the evolution, and the quote on the inside cover was, "We need to stop responding to calls that we can prevent." And that is absolutely true. Our systems are in crisis. In Pennsylvania and across the country, we see it every day. That headlines like this, we're out of money, we need to do tax levies, we need to change things that we're doing in order to make it work properly, is absolutely true. Funding is driving everything. Doug and I had the opportunity to do a review of the ground ambulance data collection system, and that webinar is online. The data is in, folks, and no shock, we are under-reimbursed in every single category, and that creates economic pressure, which causes many of our issues. There are two ways, primarily, other than bake sales and bingo, to fund EMS systems, and that is fee-for-service revenue and tax subsidy. When fee-for-service revenue will not cover the cost of providing the service that the community expects, remember, most of those expectations, we sold them, then we need tax subsidy to cover that difference. The primary cost drivers for EMS is A, response time. The shorter the response time expectation, the more expensive the system. Why? Because the more ambulances you need sitting around not doing anything in order to be able to get to that call. ALS versus BLS, for obvious reasons. It's expensive to employ paramedics. You have to pay them overtime, do all sorts of things to incentivize them to work. When I was at MedStar, we would offer paramedics incentives of up to $600 to work a weekend night shift, and they wouldn't do it because it was more important to them to be home on the weekend with their family. And honestly, and arguably, that was one of the primary reasons that we started looking at tiered deployment, because we simply couldn't sustain the level of money that we were having to pay paramedics to incentivize them to work when there were only 1.7% of the patients having a critical life-threatening emergency. We back up, and the third is the deployment model. So if you staff, as we talked earlier, a static deployment, that's more expensive than a dynamic deployment where you've got more resources on when there are more calls and less resources when there are less calls. The problem with doing flexible deployment, excuse me, is you cannot do flexible deployment when you're working 24/48s or 48/96s, unless you hire people that are going to work 10, 12, and 14-hour shifts in addition to those folks. The National Association of EMTs did a flash poll and a survey of agencies across the country, and because of all these economic issues, many systems are changing how they respond to calls. There is no better time to ask for permission to do something different than when there's a crisis. Look at what happened during the pandemic. We did all sorts of things differently because during times of crisis, the unacceptable, the previously unacceptable, become normal. because we just have to change. One of the organizations that we're actively involved is the Academy of International Mobile Healthcare Integration. This is the international association of the highest performing EMS systems in the country. Flexible deployment, tiered deployment, control center operations. They're all accredited EMDs. They're CAS accredited. External reporting requirements. They're very transparent with the data. In 2022, of those systems, only about 36% were doing tiered deployment. Many of them still had still had single deployment, all ALS units. By 2024, all of them had switched to tiered deployment. And many systems, the two studies that we showed recently that we're doing now, in both of those systems, based on the analysis of the clinical, operational, and financial impacts of this particular change, we've recommended they go to all BLS ambulances with a few fly cars that are ALS. Much better clinical proficiency, much higher retention from paramedics. They're not going to get burnt out because they're tied up on these BLS calls. Costs go way down, and EMTs love it because now they're in charge of the truck. They're not just stretcher fetchers for the paramedics. Makes sense. Many of these communities also got realistic with response times. And you'll notice that in two of these communities, one is Sunstar in Pinellas and Cambridge, Massachusetts, there is no required response time for a low acuity medical call. 911. The community says, it's low acuity, get there when you get there. Seattle's the same way. Today in Seattle, if you call 911 with a low acuity call, the call goes to a nurse triage, which is great. Once the call goes to the nurse triage, even if an ambulance is necessary, the contractor doesn't even report the response time. It doesn't matter when the ambulance arrives because the patient's been triaged as low acuity. One of the interesting side notes, when we were talking about some of these systems that have transitioned to these 30, 60, 90-minute response times, they said that many times they'll get a repeat 911 call. So they'll say, hey, call back if anything changes. More often than not, they'll get a call back in 30, 45 minutes, and the caller says, hey, my neighbor's going to take me. I'm good. You can cancel the call. Oh, thank goodness. Maybe you should have done that first, do not, and would have been much easier. Now, if we are able to do this and to do some of these modalities, the savings to Medicare is going to be significant. We need to sell transformation based on what you're going to hear later on the legal foundation. But I'll be honest with you, I've been in EMS for many, many years and have been working with Congress and have testified before the House Ways and Means Committee and had to write papers. This is about the money. Congress, other folks will say it's about the medicines. It's not. It's about the money. The only way we're going to make a case to change how systems deploy, how we treat patients, where we can take them, how we're reimbursed, is to make the economic case. If we don't make the economic case, nothing else matters. Bottom line. During the ET3 model, we're very fortunate that an outside agency was able to identify that for every patient that did not go to the ER because of an ET3 treatment in place, the net savings to Medicare was on average $550. We respond to millions of Medicare patients. If we can reduce the transport rate in that population by 20%, 25%, we proved in one of these papers that NAMT did, that we wrote for them, it's about a $1.2 billion annual savings to Medicare.
Can you briefly define for non-EMS folks what
I'm sorry, ET3 was a payment model that Medicare tested that reimbursed ambulance agencies for not schlepping people to the hospital. So if we were, because right now today, if we don't transport someone to the hospital, we don't get reimbursed, primarily. Medicare does not cover non-transport. For a period of time, Medicare covered non-transport. And that model was called ET3, it stands for Emergency Triage Treatment and Transport, ET3. There was a dispatch component that completely failed because it was designed poorly. And then you had treatment in place or transport to alternate destinations. And all the outcomes from the ET3 model, phenomenal, but very, very little participation. And because there was very little participation, CMMI could not show any savings, so they killed it early. Thank you for that ask. All right, so what's preventing us from doing these changes? The evidence supports it. We in EMS have been slow to adopt changes. How many people remember masked trousers? Right, I've seen a picture of Doug Wolfberg in a pair of masked trousers. How come these aren't on ambulances anymore? They don't work. They don't benefit the patients. They probably hurt them. Now, they were great flotation devices, by the way, but from a clinical perspective, didn't help people, probably hurt. So we took them off the trucks. Evidence showed we shouldn't use them. How about EGTAs? How many people remember those? Why don't we use those anymore? Because they don't help, possibly hurt people. Draw spreaders. I remember these. I had to check these off on our checklist. Why don't we use draw spreaders anymore? Because they don't help people and probably hurt. KED splints. How come we don't use them anymore? Because they don't help, probably hurt. We don't even use longboards anymore. Why is it that upon the first inkling that mask trousers, EGTAs, draw spreaders, KED splints don't help, possibly hurt, we rip them off the ambulances? But yet, despite volumes of data and evidence-based research that says lights and siren don't help, probably kill people. We know they kill people. Why are we so reticent to change? Paramedics on every call, paramedics intubating. Hell, I was paramedic for most of my career. Intubation was the thing, right? What separates me from an EMT is I can put a tube in your throat. Once you take that away, I've been emasculated. Sadly, it's not necessary to do that, to help people. Every study that's compared supraglottic airways to endotracheal has shown the patient outcome with a supraglottic airway is better than with an endotracheal tube. So why are we hanging on to this archaic practice? Because it's cool as get out. Culture. We got to change the culture. So we've always done it that way. Change is risky. 100 years of tradition unimpeded by progress. How often do we hear that? As Doug mentioned, we were opening, the two things that firefighters like most and fire departments and EMS people and everybody likes most are change and staying the same. So we got to be careful. Some resist the change, right? We talked about the economic issues. We've got nurses that get nervous about scope of practice, and they don't want us to creep into their scope of practice. So we've heard home health agencies, nursing unions, others say, hey, if you start treating patients in the home and they're not calling 911, that's our territory. That's going to impede our ability to get paid what we're getting paid, and we're not willing to do that anymore. There are some regulatory and legal issues that we need to overcome. However, not as many as people will tell you. Love it when somebody says, well, you can't do that. It's against the law. Show me. Prove it. And I'm sure Doug and the gang are going to talk a lot about that. The economic model is really the biggest issue, right? So if we are only paid to transport, and arguably, if you were to talk to the Blues, Aetna, Cigna, CMS, CMMI, they won't tell you, but you know that payment policy changes clinical practice. Payment policy changes clinical practice. Consider this as the most recent example. Forever, telemedicine was not a reimbursable intervention when the patient was at their residence. 2021, suddenly, because of need, CMS said, well, we're going to cover telemedicine when the patient's at home. What happened to telemedicine providers overnight? We went from 2 in the country to 2 each county. And now, when there's a threat that those waivers that allows that might expire in 2 weeks, again, some telehealth providers are saying, we're not going to do it unless we're going to get paid. So payment policy changes clinical practice. Just admit it. Yes, we need to focus on the medicine, but we really need to focus on the economics. So the requirement to respond to call, ambulance to every call is part of that problem. All right, a couple last reasons why dads should not be left alone with kids. That's a good one. At least it's a, yeah, at least they're wearing boots. That's good, yep. That's why she stopped asking how the kids are. Questions, comments, complaints, criticisms? Sir?
So the initial input for these EMS calls is a regular person who typically won't have, except apparently in Seattle, won't have any sort of medical or first aid training.
Correct.
Has there been any studies on whether the level of education or the level of first aid training in a community has a different impact on how these systems, this transformation works? Or do you need to really say, look, every high school in the country is a graduation requirement. You got to do the first aid, the Red Cross first aid course and pass it?
Yeah, and the latter part is there are some states that are doing that now. Texas, California, others are requiring that in high school you have to become CPR certified because you just need that. The reality of when people call 911, most people are not medically trained. It is up to the medically trained call taker to be able to tell them, that person, what to do. Bleeding control, childbirth, CPR, obstructed airway, whatever the procedure is, using evidence-based emergency medical dispatch, you can do that. I've done it in my career, and I got to tell you, even 5-year-olds, when they call 911 because mommy fell and she can't get up, they are amazing instructions followers because that's all they've done their entire life. So, hey, mommy fell, cut her arm off. Hey, great. Can you go get, some clean towels and wrap it around the stump for me? Yeah, sure. Does it matter what time? No, it doesn't matter. Just go grab. I mean, literally that. So it's up to us to be able to train and equip our call takers to improve patient outcomes through instructions, pre-arrival instructions.
Now, just listening to your whole lecture, there are a lot of things I think that are external factors that put the pressure on this. Obviously, the lack of primary care in the United States is what's funneling most people to be sent to the hospital, right? That's something that we can't necessarily change. We're trying to do it with mobile integrated health, but that is taking time. We're just trying to get the money on board because, as we know, the market kind of dictates what we do, right? And it's what the demand of the constituents and the people that we're actually representing or servicing who really dictate where the services go. But until we fix those problems, right, that's the thing. Like, until underlying societal issues are fixed, that's why we're going to see heavy draws on EMS. Because once again, like, I think it's a bad way to say it, but I'll say it. It's kind of like the trash men. They call you, you're going to come and take the trash.
Oh, yeah.
And that is how we're looked upon. The police dump on us because they don't know what to do. They're not medical experts, so they call us. And we're supposed to be the catch-all. So we send people who may or may not have enough training, right? Behavioral emergencies is another instance where people are not best trained in EMS, right? They get a day in class, maybe a little bit afterwards, but then they're expected to handle a whole barrage of different behavioral emergencies and understand the nuance in behavioral emergency law depending on your state.
Right.
So, I mean, like I said, I know I've gone on a tirade, but there are a lot of external factors that I think also press this.
Those external, and that's a great point, those external factors are going to get worse, especially with some of the changes that are coming down the pike. And I want you to leave this discussion with this final thought. There is no such thing as an inappropriate request for an EMS response. There is such a thing as an inappropriate response to that request. So we can't, and those of you that have tried it, we're going to educate the community, stop calling us for non-emergency calls. It's not going to happen, right? People just, they're going to do it. Our responsibility as effective community and EMS leaders is to use the evidence and the data and processes that are evidence-based to say, you called 911 because you don't have a primary care physician, you've got the sniffles and a fever. We're going to connect you with a telehealth provider here from the 911 center who's going to get you a prescription to help you relieve your symptoms, blah, 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 and we'll get you an appointment with a clinic for tomorrow. We're not coming because we don't need to. Tying up resources for that call is stupid because the next call is the baby not breathing. It's up to us to build those systems to be able to manage the low acuity call better. Yeah, and that's why we get these calls. We can't afford a $2 million subsidy. What we can get for 100? Seriously.
Matt, thanks very much for being here. You know, I've kind of followed you for, I'd like to say, a couple decades, but I don't remember because I'm that old. And this is not just a lecture from you. This is your belief. It's how I interpret it. I mean, I've seen you I don't know how many hours you've been away from your family to spread this message, and I just love it. And I walk parallel in your message. You're much more articulate, so that's why you're more successful. I try
Or
to
less successful.
I'm trying to do a lot of this stuff, that you're talking about. I have for years in the South Central Pennsylvania. The question was asked. Joe asked a question about, the difference in the PSAP versus a direct communication. I can tell you, in communications with our PSAPs, they are ready for this. They have a call volume that what they want help with. Our state medical director is ready for this. I think the movement of this is really ours. And I think the gentleman just asked that last question. I think what's lacking is EMS speaking for EMS, EMS providing a vision of what they want to see and to be those experts in the field. However, a big stumbling block I've had over these last handful of years is, I think, the most basic part of every part of your presentation. Can you define low acuity versus high acuity?
Sure. If you want to be specific about it, it's an alpha, bravo, or omega level call. And the reason I responded that way is because there's an evidence-based process of getting information from the caller to say whether it's chest pain, snake bite, abdominal pain, back pain, whatever it is. Once you ask specific questions, you get to an acuity level. For those of you using APCO, APCO has the same process. Stable, unstable, critical. APCO, most of these EMD systems use a question and answer process to come up with what's high acuity, medium acuity, low acuity. So when somebody says to me, what's a low acuity call? If you're an EMS person, I'm going to say it's an omega, alpha, or bravo level call. Bottom line. In medic, it's a Charlie level call, but it's a whole nother discussion.
Matt, we have an online question.
Yes.
When earlier in your presentation you were talking about hospital admissions, do those include cardiac arrest or critically ill who never made it to the floor or who are transferred?
Yes. So there are some cases where a cardiac arrest went to the emergency department, wasn't admitted, but we know that cardiac arrest is what? 0.5% of our call volume? It's not going to move the needle. Great question. And by the way, before Doug cuts me off, if you are not assertively doing field resuscitation termination, look into that, because today, very few, in most systems, very few unsurvivable cardiac arrest cases end up in the ER anyway. They are appropriately terminated in the field, and you can thank Dr. Kupis for driving a lot of that change.
Please join me in thanking Matt Zavodsky.
Thank you.
Folks, we now have a 10-minute break until the top of the hour, and then we will start back in. Thank you. Okay, folks, let's go ahead. We'll get started with the next session here, which I'll be presenting. And I looked at the schedule and I thought, what idiot put me on after this keynote, this amazing keynote? I realized I was the idiot who set up the agenda. So I have the unenviable task of following Matt Zavodsky. And you can now see why we immediately hired Matt when he became a free agent a couple of years ago out of Texas, and is really leading the way, I would say, of EMS transformation across the United States, and has been impactful in so many systems. One of my favorite quotes was that of Senator Edward Kennedy, who said at the funeral of his brother Robert Kennedy that some men see things as they are and say why, and others dream things that never were and say why not. And I feel like whether he knows it or not, that's kind of the same mindset that Matt brings to EMS, is to question the status quo and say why can't we do some of these things. And if I had my way, we'd just make the whole day that kind of stuff and let Matt lead it. But we've got to move on and talk about some legal stuff as well, since this is a CLE as well as an EMS continuing education session. So now we're going to sort of transition into this discussion of some legal barriers to EMS system transformation. So this is really kind of piggybacking on what the last guy said, right, on what Matt said. He set the table for EMS transformation, and I'll be talking about some of the legal obstacles that we've seen really in our practice. This is not a broad evidence research-based review of all EMS laws in the country. This is really just a sampling of some that we've encountered in our practice that, when improperly applied, can pose barriers and obstacles. A couple of those are here in Pennsylvania. Some of the folks in this room will have had some involvement in some of these in some way and preventing some of these bad things or correcting them, and others are from other states. It's just kind of a random sampling of case study of laws, regulations, even policies and protocols that can stand in the way of the vision of transformation that Matt was just laying out. I want to particularly thank Attorney Scott Jochen for his not only great AI generation in that image, but also for most of the research and drafting of this content for this presentation. So thank you, Scott. So first thing is that transformation is no longer optional. The stuff that Matt was talking about, it's patient-centered, it makes good operational sense, it makes good financial sense, and it also makes good legal sense, as I hope to argue or present in this particular session. And because of the unprecedented challenges that EMS faces in terms of operations, in terms of workforce availability, in terms of financial resources and sustainability, this idea of traditional transport-only mindset, those models are misaligned with what patients need, because we can meet patients where they are and give patient-centered care. I think if you gave most people the option, can we manage your condition right here in your living room in your cozy recliner versus going into an emergency department, which, as Matt said, is not the instant ticket into a bed in the ER, right? You're going to wait for hours in many cases on end, whether you come in by ambulance, whether you come in on your own in your own vehicle or an Uber takes you there, right? The wait, particularly for those lower acuity conditions, is going to be long. And by the way, one of the things that we'll touch on a little bit later, we've talked about in more detail in prior years' EMS symposia here at Widener, but those low acuity calls, when ambulances transport low acuity patients to emergency departments, it's for those cases that those ambulances and those clinicians are likely to be waiting for hours with the patient in the emergency department to be able to offload or transfer that care to the hospital emergency department staff. I'll talk about that a little later. Anyone in EMS knows how I feel about that, and we'll talk about that a little bit later. But and every hour or unit hour, as we call it in EMS, the hour that we staff the unit and it's in service, able to respond to calls, is wasted when those unit hours are spent literally babysitting low acuity patients on a stretcher who are no worse off than the patients who are already sitting in the waiting room who came in with the sniffles under their own power. So this idea that somehow we've committed patient abandonment if we leave a patient who's stable, low acuity, before Nurse Ratchet nurses in the emergency department physically assumes care of the patient, right? Why is it not abandonment if the hospital doesn't assign a clinician to every person with a similar condition seated in the waiting room? So the idea of legal barriers to system transformation starts with this idea that, and Matt touched on this, that, there's this liability fear that there's going to be a lawyer behind every tree and under every rock if we make these system changes. But that's why we started today with evidence-based practices. If the data and the evidence show that what we do is safe, it's patient-centered, and it's clinically effective, and will help and not hurt outcomes, then you find me an expert witness who will get on the stand and testify against the EMS system that does these things, right? Because if they are being evidence-based and clinically driven, they will not be able to make that case against EMS. So when everybody's worried about liability, Matt and I sort of found that over the years we were using this same statement. People will have you believe that bodies are being stacked like cordwood at City Hall because the ambulance system wants to make changes that will slow down response times for low acuity patients, leave patients in hospital emergency departments, and get back to your community when those patients are low acuity, and all these other things because, oh, there's too much liability to do that, or that's patient abandonment, right? I like to say, that never sounded right to me, so I went to law school just to make sure, right? Those are not legally accurate statements. And when we are transforming into evidence-based deployment and modalities and the kinds of care we provide, Matt said same thing about lights and sirens. I'll say the same thing about legal statements. When I hear, can't do that, there's too much liability, we'll get sued, that's abandonment. Why are we so quick to throw out those isms when we're so evidence-based and demand data and science to do our clinical care? But we're so willing to believe nonsense. Oh, liability. Oh, glad you mentioned that. Boy, I never thought of that, right? So that's really the idea here, is to take what Matt said and deflate some of those legal barriers and point some of those out so that we can be vigilant about the legal infrastructure, because we all operate under state enabling laws, right? Those state laws determine what an EMT's or paramedic's scope of practice are. It determines what things a licensed ambulance service can and can't do. And that legal infrastructure is what allows or doesn't allow the kind of transformation that Matt was talking about. So the question is not whether we evolve, but how quickly and how we do those things. So Matt laid out that case for better care, for transformation in how we deploy, how we provide clinical care, rethinking that whole thing in a patient-centered way. This focus is to look at those legal choke points, right, that prevent that vision from being realized. And clinical innovation is really no longer the limiting factor. And this morning when I gave some brief introductions, I was saying that Steve Lyle and I were talking before we started about how, now we're dinosaurs. The piece I didn't mention was that it's really exciting to see the profession start in the last maybe 10 to 15 years be so evidence-based, to discard practices that were long held, right? When Matt put that slide up, mask trousers and airway, jaw spreaders and KED boards and all that other stuff that a lot of us used, right, back in the day. In fact, in Pennsylvania, some of you will remember this, if you were an EMT basic and you became an EMT before mask trousers became a thing, you got a separate patch, ladies and gentlemen, that went right below your EMT patch that said M-A-S-T, right? And man, you better believe I had that on my sleeve. So the point is that when we let go of those traditions because the evidence shows they don't work, that's great. But it's a little bit sad for those of us who are on the back nine of our careers to not be able, to not be here to help drive and to see what will happen in the next 30 or 40 years, right? Because the pace of change now is accelerating so rapidly, and that's great to see. But the laws that we depend on that set that legal infrastructure are not keeping up. Some state statutes, regulations, policies have failed to keep pace with this modern idea of EMS delivery and these care modalities and models that Matt was talking about. Laws have to facilitate patient-centered care and flexible modalities. Some don't speak to this, but some actively prevent it, all right? And I want to be clear that this is nobody's fault in particular. This is really a consequence of the fact that most of our state EMS enabling statutes in most states in the country were written at a time when EMS was basically one thing. It was, you get dispatched, somebody calls 911, they dispatch an ambulance, the ambulance responds, you provide some treatment, you put the patient in the ambulance, take him to the hospital emergency department. When you're writing statutes that say licensed ambulance services, certify or licensed personnel to do these things, this is what it looked like when those laws were written, right? So that is nobody's fault. And a few of us in this room were some of the people who sat in those rooms when some of these laws were written. When I was a college student at Penn State doing my undergrad, I did an internship at our state EMS council where one of my projects was to help organize the regulations that were being written for the EMS Act of 1985, right? To be a little dinosaur-like here. So at the time, those are the systems that we were writing to describe that reality, right? And there was no way that we could foresee the types of things that Matt was talking about today. So identifying these legal barriers is only the first step. Without reform, progress in service delivery and the care modalities and the innovation will stall if we do not have a legal structure in place to embrace or allow it. And those clinically sound, patient-centered models will be blocked, and in many cases they are, just because they are non-traditional. Because Matt said it right, that we are resistant to change, just as a species, by and large. And if we do things that are different from the norm, because the laws that describe our system were written 30, 40 years ago, right? We can't deploy and operate in a way that allows for the sustainability that Matt was talking about. And then patient access to care could be impeded. Case in point, if my ambulances in my community are spending hours in an emergency department waiting to transfer care for those low acuity patients, they are not available for the next high acuity emergency within the community. And if we're doing that because we're laboring under an incorrect understanding of what the law requires us to do or doesn't when we're handing off that patient in the hospital emergency department, our systems can't be sustainable. This is all by saying there's a direct link between our understanding and embrace and development of the law and the ability to be sustainable, patient-centered, and flexible, as Matt was talking about. Questions, thoughts, comments thus far? Okay, let's talk about putting some of these laws and rules that we're going to talk about into maybe 4 broad categories, and then we'll look at some examples. There are laws that really say what EMS does is give people rides to hospitals. And some laws are built and centered around the idea that what we do is transport people, right? And we got very close but didn't quite close this loop between what Matt said and what I'm talking about. And that is, and Matt said this, EMS reimbursement is based on the transport of the patient as the unit of payment. And again, nobody's fault, but that's primarily because when the Medicare statute was enacted, anybody know the year? This is always my trivia question here. What year did Medicare become law? 1965. I always remember that because Medicare came into existence the same year I did, ladies and gentlemen. So easy to remember. So, which is now, last year it was very easy math, 60 years. So back in 1965, EMS was really any vehicle that had the capability of transporting a person horizontally. And for that reason, where did a lot of EMS originate? Funeral homes, because they had vehicles that were built to carry people horizontally. And if you think about it now, that's a really excellent case for business vertical integration, isn't it? They don't make it, bad EMS humor. So laws that default to transport are one category. Second category are laws that restrict practice of EMS clinicians tied to where they work rather than their clinical competence. These broad categories will make more sense when we do examples from different states. Third, operational mandates that delay handoff or release or impede EMS availability. I sort of already gave you an example of that. And then fourth are structural or political barriers to efficient system design. We do, whether we like it or not, operate in a political environment. Statutes are always going to be subject to interests and lobbying and groups that have power and influence and money, and we're going to do some examples of statutes that are not the best from an EMS system design standpoint, but that favor some constituencies who have more political juice over others who do not, all right? So those are the four categories. And I have to say that some of the laws and rules that we're going to talk about are candidates to be enshrined in what I call the Stupid EMS Law Hall of Fame, okay? And yes, there's a logo for it and everything. I have actually started collecting folders of these examples that I may put this out on social media, let people vote, and then every year I will do new admittees to the Stupid EMS Law Hall of Fame. So some of these are candidates for the first class in the Stupid EMS Law Hall of Fame. All right, first category are these transport default laws and rules, all right? And this is probably the most archaic piece of our EMS legal infrastructure. Many statutes, rules were built around the central premise that the job of the ambulance is to transport a patient to a hospital. Non-transport, which is almost all the modalities Matt was talking about, right? Non-transport is seen as a deviation and not as a legitimate EMS outcome, even when research shows, and that's why we started with the evidence-based case for transformation, because the research does show that for many cases, that transport to an acute care hospital emergency department is not clinically needed by the patient. They will not suffer any adverse outcome without that transport. The problem is not that EMS clinicians don't know how to identify those low acuity patients. And there was a question in the last session, what's low acuity? Matt answered in terms of the dispatch criteria, right? That with proper interrogation of the callers who call 911, we can differentiate between what is likely to be a high acuity and a low acuity patient. EMS clinicians, their training, their clinical expertise, getting better all the time, can effectively differentiate between high and low acuity patients. The problem is that some of these EMS laws might not trust them to do that. Because remember, these laws were largely written in a time when we did not have the level of clinical sophistication that we do now, right? So don't make those decisions in the field. Put everybody in the ambulance, transport them to a hospital where the real clinicians can check them out and make sure, right? That was kind of the mindset that many of these laws and rules originated under. So transport is framed as the legally safe option. Laws and regulations may, whether they intended to do it or not, discourage those alternative types of services. And then the clinical judgment that the EMS clinicians can exercise is more narrow, more limited, and more constrained. And it may be a fear of liability that underlied a lot of those laws and regulations when they were written. Could you please sign this waiver confirming that you won't sue us for not transporting you for your skinned knee? Now, ladies and gentlemen, I realize here this graphic is asking a minor to sign a refusal form. So I get that. But the point is that there's, the statistical majority by far of our calls are for these low acuity conditions. If we build a system around the minute percentage that are high acuity, that is an ineffective allocation of resources. So the first law that we're going to take a look at in this category of transport default is the state of Arizona. Our legal citation is here. This is statutory. And under Arizona revised statutes, this particular law governs EMT and paramedic conduct related to patient transport decisions. This was enacted just short of 4 years ago. I'm going to show you just a short video on how and why this law came about.
Also tonight, our other big story, a call for help turns into a negotiation for a ride to the hospital.
That ambulance is $1,500. I mean, we'll take her. You got $1,500. I know what I'd like to do with $1,500.
Dozens of people are telling ABC 15 their stories of how they or their loved ones were experiencing medical emergencies, but felt paramedics were trying to prevent them from taking an ambulance.
ABC 15 investigator Melissa Blasius has the video proof tonight of the firefighters' questionable behavior.
Inside her South Phoenix home in August 2021, Heidi Pate was getting sicker by the day.
I remember I have a hard time to breathe. So finally, the kids convinced me and they called for help.
They told 911 Heidi, who was 61 at the time, had COVID, was having difficulty breathing. She was told to go out front. Nobody realized the Ring doorbell camera was recording clips from the moment the exam began.
Hey, let me see where your stats are. If your stats are good, they're not going to really want you at the hospital.
The fire captain grabs a seat and joins in.
Are you related, sir? Yeah, that's my mom. You just want to take her to the hospital? Yeah, she wants to go to the hospital. You want to take her?
When Heidi's son won't agree to take mom himself, the captain starts talking about cost.
That ambulance is $1,500. I mean, we'll take her. You got $1,500. I know what I'd like to do with $1,500.
My feelings got hurt to make me feel like, hey, I'm wasting my time with you, or you wasted my time.
No ambulance came for her that day. Heidi's the first person we found with video evidence, but not the first to tell us they felt like Phoenix firefighters either refused them an ambulance or tried to convince them they didn't need one. The ABC 15 investigators made multiple requests for records and interviews with the fire chief. We wanted him to watch Heidi's video and answer questions about how patients were treated.
Chief Duran, Melissa Blasius with ABC 15. I've been trying to get a hold of you.
Last week, we caught up with Fire Chief Michael Duran at a city event.
I'm going to have to get more information on this and get back to you.
I've been asking your department about this for 6 months now. I have video of a situation. Is it acceptable for firefighters to tell people an ambulance costs $1,500 and they probably have better things to do with the money?
Our policies are to take people to the hospital when it's appropriate and deemed necessary. If a patient has to go to the hospital, we are to transport them to the hospital.
Fire department, what's the address of the emergency?
Our ABC 15 investigation started 6 months ago with Bruce Sandberg, who now has a legal claim against the city.
I trusted these guys. I believed them. I trusted them. Big mistake.
He called 911, asking for an ambulance for his wife, Francesca.
She just said, please call an ambulance for me.
They're coming. They are coming.
Phoenix firefighter paramedics determined she was like any other COVID patient and did not need to go to the hospital. Sandberg insisted firefighters at least help her into his truck.
And the last thing she said to me was, are we there yet, honey? Are we there yet?
Francesca lost consciousness before reaching the ER and died from a heart attack. Those firefighters were out of Station 50 in North Phoenix. A different crew from that same station went to Donna Dominguez's house in July 2021.
I do remember them saying it's expensive to transport you, and we really don't need to transport you. I remember almost begging.
Instead of begging more, Donna says her daughter drove her. The hospital report says her colon had ruptured and she was in sepsis. That's very different from what the firefighters' report said.
They said I refused and denied several times in the report. It makes me honestly lose faith. These people are supposed to be here to help us.
A state law that took effect in September bars paramedics from diagnosing patients and bans them from counseling a patient to decline EMS transportation.
We are following the new House Bill 2431 and providing trade-in to our members for that. So thank you very much, Melissa.
Are you willing to look at actual firefighters who aren't following the rules, sir?
Back at Heidi's house, the firefighters had more excuses.
To be honest, I just worked in the ambulance. All the hospitals were shutting down.
As soon they left, my son took me to the hospital, to emergency, immediately.
Heidi Pate is thankful for her son and the hospital staff that cared for her for the next 6 days. You see, she had COVID pneumonia. After that ordeal, she wants the fire chief to know.
I could tell them right there in their face, they denied to help me when I needed the most.
I'm investigator Melissa Blasius, ABC 15, Arizona.
So last year when we met here in the symposium, we talked about the reality that we all operate now under, cameras everywhere, right? This is a Ring doorbell camera. We have police body-worn cameras. We have EMS body-worn cameras. We have bystander cell phone cameras. And, regardless of whether or not the patient's acuity, and she had pneumonia, and you didn't see much of an assessment happening through the door via Ring doorbell here. But that point aside, right, the idea here is that things like, well, it's $1,500 and you got $1,500. I know what I'd like to do with $1,500. That does not play well on the 6 o'clock news, as we just saw, right? So now, a House bill was introduced in Arizona, and that became law. And that law says, as you see here, an EMT or paramedic, emergency medical care technician, as they refer to them by category, may not counsel a patient to decline transportation except as part of one of these specific types of programs that includes quality management, et cetera, which you should have anyway, right? You should have that clinical oversight, retrospective case review, quality assurance data, and all of that kind of stuff. The law goes on to say that an EMS provider may not provide a presumptive medical diagnosis and use that diagnosis as the basis for counseling a patient to decline emergency medical services transportation. So even outside of one of those formal treat no transport programs, right? So you got to have some formal program that blesses your modalities to be able to do that. But this says on an everyday basis, you can't really talk to the patient about what you think is wrong with them if that is in the context of a conversation that could be even interpreted as, you probably don't really need to go to the hospital, okay? This is therefore a significant transport default, largely because of the types of reporting and public-facing cases that you saw. And an EMS provider shall explain the risks and consequences of the patient not being transported. Fine, we should be doing that anyway. We should always be engaged in a collaborative dialogue with patients about the risks and benefits of being transported or not being transported, and of the treatments and interventions that we provide, which destination we go to, because many patients are not going to be best served by going to an emergency department. Some can go to alternative destinations that are better equipped and better suited to care for their condition, right? Whether that's psychiatric, mental health, substance abuse, whatever it is, there may be destinations that are more appropriate to care for their condition. So what this law means is that clinicians can't guide away a patient from an ambulance transport, even when that is low value or unnecessary, unless they're operating under a specific type of program. EMS clinicians are prohibited from using those clinical impressions, a presumptive diagnosis, to explain why transport may not be needed, and the law mandates explaining the risks of not going. But on the other side of which is fine, but on the other side of the equation, limits the ability to talk about why not going might be a reasonable clinical choice, right? So it does not allow for that unfiltered, unvarnished, collaborative decision-making process with a patient as a default in everyday service, right? And that's one of the problems. By the way, we have now twice stumbled over the word diagnose or diagnosis, and I know that that is a hot button in emergency medical services. The conventional wisdom is EMS clinicians don't diagnose. What the hell are we treating, right? So this idea that we are not a diagnostic profession in the sense that we don't say, here's a diagnosis and a treatment plan for that condition for the next 6 months or year, whatever that's going to take. I get that, but we make differential diagnoses which are the basis of the treatment that we provide in the field. If the patient has this condition, we're under this protocol. We don't get to that protocol unless we've been able to differentiate the condition. Call it a diagnosis, call it an assessment of a condition, call it whatever you want, but that is in essence what it is that we do. The law presumes that clinicians in the field are likely to unduly influence or pressure patients rather than properly educating them. Now, was the case we saw on the news the best example, right, of a counterpoint to this? No. But what's interesting, and that the Action News 15 reporter didn't tell you, right, the Ring video caught on camera, is that Medicare, CMS, actually has a form that ambulance services must use in certain circumstances to specifically tell people that the services they're seeking are likely not to be covered by their insurance. to use in low acuity situations, right? It's called an advanced beneficiary notice of non-coverage. So even federal rules speak to educating patients when the services they seek fall outside of what their insurer is likely to pay for. Of course, that was not mentioned in the News 15 research story here. The law ignores that informed refusal decisions are a standard of care, not only in EMS, but across the healthcare continuum, and that EMS clinicians already know how to assess a patient's capacity to make decisions and explain risks and benefits and document patient decision-making. And this idea is evidence-based and patient-centered. And this law, this type of law, can have a chilling effect to discourage clinicians from having legitimate, clinically appropriate discussions with patients about what care or transport is best for them. And this shifts this to, again, liability avoidance and transport as the default outcome, because I do not want to be the EMT or paramedic on the fuzzy end of that lollipop if I don't transport a patient and they make a complaint or there's a bad outcome, right? So now that chilling effect permeates how the system provides services, and it's the antithesis of being flexible and patient-centered. It's that monolithic dispatch, respond, treat, transport, right? That becomes a statutory default. And the patients receive less meaningful information, and true informed choice is replaced really by a one-sided warning or discussion that ultimately reduces patient autonomy under the banner of safety, and it could lead to an increase in patient out-of-pocket expenses. What this story also didn't tell you is that, fine, if the law defaults that we've got to take you to the emergency department, we will, but that does not prevent your insurer from retrospectively reviewing this call and determining if it met their medical necessity criteria, and if it didn't, they're not going to pay for it, right? So not to say, you got $1,500, I know what I'd do with it. That was not the right way to have that conversation. But that law in Arizona does not prevent Aetna, Medicare, Medicaid, Blue Cross, or any other insurer from looking at that and going, I don't care, it's not covered, right? It's just not medically necessary that they took this person to the hospital. And the bigger picture here is that because of the growth in low acuity and clinically unnecessary transports, that strain, that domino effect on emergency department overcrowding, EMS units being detained in those hospitals for extended periods of time, higher cost with no corresponding benefit in clinical outcomes, all of those things that Matt set up for us can then be results of that. Questions, comments, thoughts on our first state case study? Okay. Oh, yeah. Is that on?
No. How about now?
Yes, thank you.
So maybe I was in Philadelphia for way too long, but 99%, so even though 99% of the folks that we see are low acuity, easy in and out, easy game plan, you know, but most of our decision making always revolved around avoiding litigation for that less than 1%. I guess how in the world do we move into a system more where we have the ability to not transport and to treat people on scene or to refer them to things that they need, like more primary care type stuff instead of treating to the ER?
Yeah, so we're trying to sell that one seminar at a time, I guess, which is exactly why we're here. But the idea is really, you know, you've heard the saying, all politics is local, right? I mean, we have to, and Matt talked about this, because we have in many ways hoisted ourselves on our own petard, right? We've dug ourselves into this hole because we've sold the public on faster and, you know, all of these other things. When we report to our communities, if we report on our response times or we show up at a city council meeting to talk about our service, if we're not changing the conversation and talking about our clinical metrics and reframing it, we're only reinforcing the status quo, right? So a lot of that is in our hands in how we do that. So we've got to educate the public. It is unfortunately easier to scare them than to educate them, which is why you'll see some people, well, the EMS system's failing because ambulances are taking 12 minutes instead of 8 minutes to get there 90% of the time, right? And your mother or your grandmother or your aunt or your kid or your whoever is going to die, right? That's the narrative. And if we don't start changing that narrative on the local news, we're never going to sell that at the local level. And secondly, we take the evidence and the research and the data to build the case. This is not an overnight system transformation. Just because Matt and Doug stood up here, and Steve in a minute, in a little bit after lunch, will talk about these transformational ideas, it doesn't mean that your communities can implement them tomorrow. Part of it is to identify these barriers, which is what I'm doing. Part of it is to embrace the research, which is what Matt did. Part of it is going to be to prepare your people, which is what Steve will talk about. So it is multifaceted. We've got to come at this educationally, research-based, politically, economically. We got to fire on all cylinders, which is why the agenda today is no accident, that we're talking about the transformation, the legal system, the people side, right, to try to give you a well-rounded view of how to attack these issues. But thank you for that question. Okay, let's move on closer to home, right here in the Commonwealth of Pennsylvania. And we're going to talk about something that did not come to fruition, that could have been a system impediment. And give an example of that. Some folks in the room here were centrally involved in that. This case study that I'm going to talk about, Dr. Bledsoe, because we have his clinically informed leadership in Pennsylvania, understood the ramifications and the arguments and was a key leader in making sure that this did not become an impediment in our system. But it's an example of A, vigilance, right? B, clinically informed decision-making, and C, advocacy when we see those things on the horizon. So this I would put in the category of a good case study, started with something that could have been an impediment, and that system stakeholders said, wait a second, let's make sure that we're doing this properly and using the correct sort of approach. So this was a protocol, not a statute or a regulation. So we're talking about a sub-regulatory piece of guidance. This was a protocol that we put under the heading of statutory or of a transport default for reasons you'll see here. And this was a protocol that was in draft form a few years ago on initial patient contact that sought to define clinician responsibility after that contact. And the problem was it put that idea of a patient abandonment into a clinical protocol, which just right out of the gate is a difficult clinical fit, right? Because abandonment is a legal concept that we determine in court, and protocols are sort of step-by-step clinician guidelines, right? So the protocol basically said that when you assess a patient, the draft, I should say, that when you assess a patient, it establishes a clinician-patient relationship. Once that relationship is established, you have the responsibility to that patient until appropriate transfer of care. And if you do not follow these protocols, that is patient abandonment, in essence. This raised some red flags with us and other stakeholders in Pennsylvania because, as we've already said, abandonment is a legal determination, and it's a tort, essentially, and neither the statute or regulations define what that term means for purposes of EMS protocols. And a protocol is a very difficult place to make legal determinations, right? Protocols should be, if your patient is not breathing, do this. If their heart's not beating, do this. If this limb is broken, do that, right? Very step-by-step, clinically based decision-making. With the Ambulance Association of Pennsylvania, a co-sponsor of this program, we were involved in doing advocacy, and the slides talk about some legal basis for that advocacy and why incorporating a tort standard into a protocol can be legally dicey. These slides sort of develop that idea a little bit more. And I think one of the main concerns was that we didn't want plaintiffs' attorneys who would bring lawsuits against EMS agencies and clinicians to be able to weaponize a protocol that this is now abandonment, right? That's a legal determination that if that is relevant in a civil case, you would ask a jury to make that under the law of negligence, right? Was there a legal duty? Was there a breach of the duty? Was there damages? Is there causation? Was that breach a legal and approximate cause for that patient's harm? But putting that into a protocol and saying, if you didn't do these steps in this order, not only did you violate a clinical protocol, which there should be a consequence for, either through just culture, your clinical QA, state licensure sanctions, whatever those sanctions may be, but now you have also committed abandonment. And that could be a starting pistol for plaintiff's attorneys in every case where there was a clinical protocol deviation, right? I hope I'm making some sense here and everybody's tracking what I'm saying here. So the outcome could be to default again to transport to avoid abandonment allegations, and that would increase the chances that non-transport could be seen as legally indefensible. Again, transport being the safe option if you're the clinician who doesn't want to get charged under this protocol. Non-transport could be seen as presumptively wrongful. Legal risks instead of clinical judgment can drive decision-making, and the culture of transport could be sort of reiterated. Again, because of advocacy and enlightened clinical leadership in our state, right, this ended up not becoming one of the protocols. State and local agencies are always working on the protocols, but kind of the lesson here is to always not just look at statutes and regulations, but policy, protocol, operational level stuff. Matt talked about light and siren use, right? And how the data show not only is it clinically not helpful, but in a general sense, it's more harmful because of the contribution of lights and sirens to motor vehicle crashes involving emergency vehicles. We have to look at everything we do clinically and operationally and say, is there evidence that it benefits patients? And if it doesn't, why are we doing it, right? And this is another example of that we couldn't have corrected without appropriate both advocacy and clinical leadership. So I put that one in the positive category, but through education and advocacy and clinical leadership, that was a system impediment that did not come to be. Questions, comments on that case study? Hold on, we'll have. Well, we got to get it for the Zoom folks.
So just something that's still sorely lacking is that definition of patient contact.
Yeah.
Because in every version of protocol, and not just Pennsylvania, across the board, I've looked at several other ones, that the reluctancy to define what is patient contact, so it kind of defaults to each agency to come up with their definition of that.
Got me smiling, Steve, because
nobody wants to put a definition out there.
Yeah.
And we'll go with it. But.
Well, that question has come up a lot, and that does come up in protocol development, and we've dealt with this in numerous states, not just Pennsylvania. What worries me is that if a definition in a protocol or a policy or a reg or anything else says that patient contact is when you make visual assessment or visual contact with the patient, you're going to get EMTs and paramedics hopping out of their vehicles going, I don't see anything, right? And a medic is going to look at the EMT or the first responder and go, yeah, wait, sorry, I don't see the person laying there. You're saying they don't need ALS? Great, okay, thank you, we're out of here, right? Because if I look at them and make visual contact, boom, that established that relationship, right? But this is, again, a perfect question to illustrate why we have to be informed by legal concepts to make those kinds of policy decisions. What's the definition of negligence, right? The elements of negligence. Legal duty, breach of duty, damages, proximate causation. Do I have a legal duty to that patient when I got dispatched before I even got to the scene, let alone looked at? So if the definition of patient contact is when you make visual assessment of the patient, that ignores the fact that you had a legal duty to them well before that, right? So if it's artificial that I'm not going to look at the patient because then I'm worried I established a relationship or clinical relationship with that patient, it ignores the fact that you probably already had a duty to them. What is appropriate is if I assess them and not be afraid to look at them because of the protocol, right? I can make a clinically driven determination that they are not going to need this level of care or this transport. And then what I can do is make a clinically appropriate determination to end that relationship, almost like a discharge from EMS, right? So that has to, again, be clinically based and clinically informed. But that is another really good example, Steve, of where clinical policies can impede system transformation if we don't let that assessment happen because we're worried about when the relationship begins, and therefore we're reluctant to do the full assessment on the patient. At least that's what we've seen as an effect of some of those kinds of policies. But that's a great point, which is exactly what the kind of stuff we're talking about here.
I just want to add a follow-up on his question, and for clarification purposes, in a tiered response system, dual response, you have a service that arrives on scene, and there's a higher level of care service that's coming behind them. And then once that higher level of care arrives on scene, who then becomes the person that's in charge of that? Who makes that clinical decision once they're on scene to determine what type of services that patient needs?
Well, I think legally, I think statutorily, Matt Konya, I'm looking at you, that is still the case, that the person with the highest level of certification would be in charge of the clinical aspects of the care, right? But that doesn't always translate into operational, right? If you're operating in a fireground scene, fire chief's going to have operational control under incident command, right? But clinically, it's going to be that highest level provider. But that, right, and we know Medicare enshrines that idea that an ALS provider can do an assessment and release the patient for care and transport by BLS, which is the tiered model that Matt was speaking to, and pay for that, right? They do compensate for those assessments. So, but to go back to Steve's point, the default shouldn't be the paramedic's afraid to make eye contact with the person, with the patient. It should be, let's collaboratively make the best clinical decision. If I'm an EMT basic, I would welcome the paramedic's assessment to make sure that if they're going to release that patient to me for transport, they're not going to decompensate and crash on me. I want their eyes and hands on the patient here to make that decision. Oh, by the way, they can then also, if the dispatch supported it, bill for that assessment. Great. So I don't know if that was responsive to your question, but I mean, that's how I see it. Any other questions before we move on? Dr. Bledsoe. Hold on, mic is on its way.
So to take that to its logical conclusion, the question of, the duty to act happens on dispatch, happens on response. What is the barrier? Why do ALS providers seek not to assess the patient? And I mean, again, and so, but to walk that out, and I think the challenge that we have as we try to refine protocols and work within patient assessments is what disincentivizes, ethically, if I make the scene, I'm going to want to look at the patient and see if I can offer them anything that helps them. That's my ethical imperative as an EMS provider, as a physician, and as just a healer. It's my imperative to help. Where have we gotten things out of order to the point that the ALS providers feel a need not to make patient contact? So and how can we fix that?
I'm also an adjunct law professor, so keep the mic handy. I'll do what every law professor does to every law student. What do you think? You were a paramedic before you became a physician.
Actually, I was an EMT before I was a physician, which made it better. Joe sitting in front of me helped precept me when I became an ALS provider after becoming a physician. And I do think that there are some documentation and regulatory requirements that we need to look at. But at the end of the day, in the emergency department, we don't have this conversation. You show up, we assess you, we do a chart. That's not a question. You get registered, somebody does a chart, your disposition is recorded. That's accepted everywhere. Why are we still trying to get out of doing an EMS chart for a patient we show up for? And
well, I'm glad I
not representing the opinions of any particular body with whom I'm affiliated.
I'm glad we let you keep the mic for that, Doc, because I think you hit right on it. And this idea that I don't want to have to do a chart, right, is we hear that. Everybody at PWW can nod along on that. We hear that so often. And I get documentation is not why people get into EMS, and it's not their favorite part of the job. But if you don't realize in 2026 that documentation for any clinical caregiver is an integral part of your job and of your practice, I hear Walmart's hiring. I mean, this is a core expectation of being an EMS clinician. And, not to get psychoanalytic about it, Dan, but the idea here that if we want to decouple reimbursement from transport and say we get paid as clinicians for clinical care, whether we transport, whether we don't, if we don't embrace the ethical and legal responsibility to document patient charts, we're never going to get there. So, well said. Sir.
I would probably request security to leave the building after I say this, but inherently some of that comes back to whoever made that original decision that EMT can cancel ALS. Even if you're dispatched according to evidence-based standards, that it's an ALS response, then you have that obligation to assess that patient. But on dispatch, you're dispatched for the sick person, which is inherently automatically a low acuity call in the mind of the ALS provider. So they walk up to the residents assuming they're probably going to get canceled because that's allowed. If that was not allowed, then the obligation is, no, you have to assess the patient. Whether you're on the front porch and the patient's in the bedroom, you've not laid eyes on them, but you're permitted to still be canceled by that EMT who sticks their head out the door and says, yeah, I don't think we need you. And they offer up a number. You get back in your truck and go home. And that trip sheet now is just strictly a cancellation that takes you 2 minutes to write, versus you going in, not being allowed to be canceled, and go in and have to assess the patient and determine the appropriate disposition. But we're allowing an EMT of lesser training, if you will, education to offer that. And there's no question there's ALS providers that have that notoriety of, do you really need me, kind of thing? And almost.
Are you advocating that EMTs should not be able to release paramedics?
If you want ALS to assess every patient that they're dispatched on based on evidence,
okay.
Yes.
You sound like a freaking lawyer. Do you think paramedics should assess every patient?
If they're dispatched on it, yes.
Oh, okay, interesting. Few hands are going up now, so.
That's why I say
Hey, Carrie, maybe we should get 2 mics going to speed the process up a little bit. Mine's right by my laptop.
So
go ahead, Eric.
This is a failure of leadership. This isn't a street level thing. If your leadership is not mandating and following what staff is doing, who they're seeing, who they're evaluating, who they're not seeing and not evaluating and not documenting, that's where the failure is. If I'm going to let my people not document trips that need documented, that's my fault. And I think that it's really that easy and that clear. We send patient surveys out after every call, and one of the questions is, if you weren't transported to the hospital, how'd that decision made? Was it suggested by EMS? Did you suggest? Did you mutually agree? And when we follow it and track it and hold people to a standard, I really think that's the crux of this issue.
Yeah, well said. Sir.
So with you treat every patient that's in front of you makes complete sense. You didn't register them. Okay, so they're in your system, they've in. So you just are clearing the board. We have a different expectation. We go to an accident, there's 3 people, there's 3 cars, but there's 45 bystanders. We now have to find out who was, and you ask the cop, and the cop says, well, I just got to get the insurance. I'm really not worried. They're over there somewhere. Now we have to pre-register, not to mention do all the registration and the tech work and all the stuff and all those pieces. So no, in that regard, our duty to act. The second part of that is, do you have this, COVID pushed a lot of people into our thing looking for purpose. Not every EMT class, how many people had an ethics component to their EMT class? So we don't give them that. If you didn't bring it, and depending on who your preceptor was, you may get a whole different set of ethics. So the concept of being able to make rational moral decisions is, again, representative of maybe the training, but also the as you put, your organization who pushes those combinations. But it's got to be held accountable somewhere. I just couldn't tell you where the best use of that moral compass should be placed in an EMT's or a paramedic's pocket.
Well said. Okay, go ahead, Carrie, and then you can head over that way for Steve.
So one question I had, kind of flipping Steve's question upside down. One of the things in Pennsylvania protocol that I think is interesting is the ALS provider has to consult medical command in order to make that decision. So the chase for the EMT to cancel is actually the paramedic trying to go for the path of least resistance. So I'm questioning, in other states, is medical command consult the norm for ALS downgrade to BLS?
No. I would just say, based on our work in other states, I would say that that does not require active medical control. Yeah.
We should do better.
Thank you, Dr. Bledsoe.
Better at that.
Counselor.
You're getting me going here because all these comments relate to what we're going to talk about after lunch. The psychology of it all, the leadership failures, and yes, the laziness that we're seeing. What's the root cause of that, and what can we do as leaders we really got to transform our workforce to deal with some of these system transformations that Doug and Matt are talking about. So we're going to hit a lot of this after lunch. So great comments.
Yeah, thank you for the preview. Okay, let's take one more a word from our sponsor.
Steve, I agree with you, but I'm not necessarily sure it's all laziness. I think we've made the system, and I'm going to say this in the wrong room, I think that we've made the system difficult to prevent you all from suing us. And I mean that in the sense of, why do we need to contact medical command? Because it reduces liability. And why don't the paramedics want to call? Because they know if they call the medical command physician is going to say, no, bring him to the hospital because it's my liability now, and I don't want to release that patient. We need to relook at this system and get realistic of what the expectations we're putting on the employees.
Yeah, and it's a horse and buggy or it's a chicken and egg thing. Because we're saying we're worried if we don't do this, we're going to get sued, right? We want to make sure we minimize liability. When you said you don't want pointed to me, to sue us, we represent EMS, as you know. It's.
Medicine's defense. Medicine is all about.
But the point is that if we make our protocols more patient-centric and allow for flexible kinds of modalities in decision-making, we will give them the protection, right? That's a robust defense. So, okay, let me move on. I'm an hour in. I've gotten to one of my 4 category areas, so I'm going to pick up the pace here. But the second categories are these practice restrictions that are restrained by where we work and what it is we're doing, where legal authority to practice paramedicine, to practice EMS, may be based on where and when we're providing it and by whom we're employed. Therefore, context and not competency determines when and where and what care can be delivered. When we get licensed or certified, and there's really no major difference between the two, but when we get authorized to practice, we are then sort of subject to a single scope of practice. It can be locally modified in many states through medical direction at the local level, but that a paramedic or an EMT have that consistent baseline of training and knowledge. But that scope can expand or contract based on where we work. If, for example, I'm a paramedic working on a BLS ambulance, I'm effectively an EMT, right? So, and that's an example that many of us are familiar with. But this creates sort of hidden distinctions within each category of licensure. I'm a paramedic, but I can't do X, Y, and Z in these settings, right? Here's a recent example, kind of recent from Massachusetts. Here is the statutory citation, 25-year-old law that says that EMS clinicians can only practice when employed by a licensed ambulance service. Outside of those settings, you're just a person with a first aid card, basically, right? There's not much you could do unless you are doing it for a licensed ambulance service. Here is the statutory language. You can't hold yourself out as an EMS provider other than on behalf of a licensed ambulance service licensed under our state laws. And these are the sanctions and remedies for violation of that. The reason this is a little bit more recently on our radar is that the state EMS office in Massachusetts kind of doubled down on this in November in a policy statement when they said you can only function as an EMT or paramedic when acting on behalf of a licensed ambulance service. Your certification does not authorize you to do things for other employers who aren't licensed ambulance services. And when you are not acting within the EMS system, you can't hold yourself out as a provider. That's the equivalent is a nurse being told you can only practice in a hospital and you can't work in a nursing home, you can't work in a school, you can't work in, industrial health, you can't work in any other setting, right? It's geolocated. Your license is based on working in this licensed ambulance. The advisory was sort of targeted to this idea that EMTs were freelancing with schools to cover football games, right? That's where this came from, that you can't just hire yourself out to go be a freelance EMT and stand on the sidelines in case somebody gets hurt, because you're not doing it under a licensed ambulance service. This is just a screenshot of the advisory. There may be different reasons for this, right? Some of which could be legitimate. We have a medical control infrastructure in place in a licensed ambulance service. You have a medical director, you have protocols, you have quality improvement, you have all these safeguards in place. But does that assume that we can't do that through other employers that might employ EMS clinicians? We can. We can put those same clinical safeguards in place in other employment settings, right? The law presumes that we can only safely function when we're working on an ambulance service that holds a license, and that other employers can't provide that same level of oversight. And limiting the practice is just a path of less resistance than trying to raise the bar for other employers. The law ignores the fact that licensure is based on standard education and scope of practice, and that these things like medical oversight, and collaborative medical practice, and QA can exist in other settings, and that our competency isn't based on where we work, right? It's based on what we know. And this can block the integration of EMS caregivers into other practice settings. And when Matt said that the temporary changes that went in place during COVID to allow for telehealth payment, for example, payment drives innovation, as Matt said. If we can have EMTs and paramedics employed by home health companies, telehealth providers, and other companies that do these modalities, right? Not only is it more economically efficient, but it's another career path for EMTs and medics who may be burned out of the EMS part of paramedicine. And I keep using the word paramedicine because I think that's the word we should use to describe all clinical EMS practice, regardless of what level of certification you hold. We all practice paramedicine, just like both registered nurses and LPNs practice nursing, right? We should be branding our profession more simply and more easily. But that is another lecture, ladies and gentlemen. This disincentivizes alternative care models, some of which Matt talked about. And employment-based constraints on our practice are kind of arbitrary. They can prevent practice across settings. They can discourage innovative staffing models, confuse agencies, employers, and others about what they can and can't do, and where and when they can't do it. I'm going to sort of defer the workforce stuff. Steve's going to talk more about workforce a little bit later. But from a bigger picture, you can see how this can limit innovation. I think this is also an opportunity for stakeholders to get involved in changing that rule. I do not, and I said this on a LinkedIn post, blame the state EMS office for putting out a policy memo enforcing a statute that's on the books. Change the statute, right? This is where stakeholders can get together and make the evidence-based case that EMTs and medics can do things in other care settings and should be permitted to do that. I don't fault an EMS office for enforcing the laws that are on their books. They must enforce those laws that are on their books. Change the law is really my point, okay? Any quick questions on that one? Okay, let me move on to another case study in Pennsylvania along those same lines. This is an old regulation in Pennsylvania, still on the books, that restricts the ability of paramedics to practice inside hospitals. And this comes from a regulation in the Pennsylvania Code. It's not statutory. We're governed by the EMS System Act. Statutory citation is here. The regulations under EMS are in 28 PA code in the chapters you see here. But there are, in some cases, in some states, anachronistic regulations outside of the EMS regulatory infrastructure that limit EMS. And I don't expect you to be able to read this. This is just a snapshot. But what this says is that paramedics may not function as paramedics inside of a hospital except in extraordinary circumstances when directly supervised or if you're training and somebody is precepting you, right? So this is a regulation passed probably 30 years ago, if not more, probably closer to 40 years ago, still on the books. And it says, in no uncertain terms, a paramedic's primary job is to work outside the hospital. Don't you come in here and start practicing inside of a hospital. You may have the handouts in front of you, you may not, but why do you think, I'll show a slide on this in a second, why do you think Pennsylvania has a regulation that says this? And other states do too. Nurses were worried when paramedicine became more prevalent and more common that they would replace nurses. Now, to nursing's credit, what did nursing do? They expanded their education. They raised the bar. Instead of certificated RNs, BSNs, masters, nursing doctorates, one of which works on our staff that's sitting here. So they raised the bar, which is great. But at first, when paramedics could do a lot of the same stuff that nurses could do, the idea was to respond with this kind of rulemaking, right? So this is economic protectionism, driving system deployment, essentially, right? Hospitals violate Pennsylvania law if they employ paramedics to work inside of a hospital and allow them to do anything autonomously in that hospital. And again, many of these, and this particular one came about at really what I would say is the dawn of paramedicine, when that economic fear for job security was prevalent. What's really ironic, rich in irony, is that most emergency department nurses welcome, expect, or even demand that the paramedic continue to function inside the hospital until they hand over care to clinical staff, right? We know that EMS clinicians have become an adjunct to hospital staff, are effectively subsidizing hospital staffing with those unit hours that they're waiting to offload patients in the ER, right? So that is rich in irony. So this is, again, kind of location-based, where you can and can't do the things you are trained to do. And like I said, this is an irony alert because of the dependence that hospitals have on EMS staff during those periods of offload time. So this is anachronistic. It is economic protectionism, not based really on evidence or clinical competence. So that is a second example of a regulatory barrier that's kind of based on where we work and not what we know. The third example category are operational mandates that impede clinical flow. We're now going to go to the West Coast, the state where I do most of my work, actually, even though I'm based here in Pennsylvania. And this is a law focused on what I just talked about. Ambulance Patient Offload Time, or APOT, is one of our newer acronyms in EMS that measures the interval between when an ambulance gets to the hospital and when hospital staff directly assume care of the patient. It's that handoff period, okay? And the reduction of that time interval is one key to system sustainability, as Matt and I both said, getting those ambulances out of those holds in the hospitals for extended periods of time for low acuity patients and getting back out into the communities, right? So these offload delays or extended APOT have already been identified as a system choke point. A couple of years ago, 3 years ago, California legislators introduced a bill, which it was AB 40, still called that even though it's now law, which was well-intentioned to reduce ambulance patient offload time. The law required the state EMS lead agency, which in that state is called the California EMS Authority, most states we call it the EMS office, requires them to track those times because the key to any transformation is to have the data and the evidence, which is why Matt was our lead-off hitter today, right? So if we can quantify it and track the time that ambulances spend in handoff of patients, we can then address the problem. However, they wrote AB 40 to say that the state EMS office shall develop a requirement for an electronic signature that the EMS caregivers get from a hospital staff member, and to capture that time when transfer of care is executed for documentation of patient offload times. So if you read the statute, the clear purpose of capturing that signature is the timestamp, right? That the signature serves the purpose to be the range of that time, offload time interval. When the signature is captured, that's our data point. The statute clearly says that signature is for the purpose of capturing the time, okay? Then, unfortunately, the statute went on to say, the signature shall be collected when physical transfer of the patient occurs and report is given to hospital staff, okay? So everybody sees the word shall be collected, and they say, this is a mandatory handoff of care signature. Much of EMS does handoff of care signatures as a tradition, not as a legal requirement. But a lot of people in California interpret that to say, you can now not physically leave an emergency department until the nurse signs your form accepting transfer of care, right? What this really is shall be collected. The word that should be bold in italics is when, right? All this is really doing is establishing the point when the handoff is complete. But the selection of these words turns it into what some people interpret as a substantive requirement. We tracking here, right? So this is clearly meant to solve the APOT problem. It could inadvertently exacerbate the APOT problem, okay? Because of the shall be collected language. And even the state EMS authority, when writing regulations to implement this law, interpreted it that way, okay? So this is just kind of repeating that. But in their regulation, their first emergency regulation after AB 40 was passed, the state EMS agency wrote a regulation that said, it had definitions in the regs. Transfer of care means when the ambulance arrives at the hospital and care is transferred to a hospital gurney, bed, chair, or other location, and the hospital staff receives report, all fine, at which point the EMS crew is free to leave, right? What does that language do? It means ambulances get detained longer because the hospital staff know you can't leave until I give you that signature releasing you. That exacerbates the problem the statute was meant to address and solve, right? So this raised immediate red flags. We've already talked about some of the advocacy that the Ambulance Association of Pennsylvania did on some issues. We also represent the California Ambulance Association, which we sort of flagged this immediately, and they said, yes, we have to do advocacy. We wrote a, I think, well-reasoned legal letter on why the state was taking the AB 40 language and overreaching to turn that into a substantive requirement before EMS gets to leave the hospital. You have to have the signature. It's a data element, treated as a data element, not as a new substantive requirement. And the state did finally delete that language in the second version of the emergency rule that it released. Those of you who have attended this before or read stuff we've written know that it is our position that the Federal Emergency Medical Treatment and Active Labor Act, which imposes the legal duty for the patient on the hospital when the patient reaches the hospital's property, would preempt a state law that would delay that duty of care, right? My point is that the duty of care belongs to the hospital under federal law, regardless of what a well-intentioned but poorly written state law like this would say, okay? So that is another federal component to state laws like this. Okay, and the slides flesh that out a little bit and have a little bit more detail in them about the legal basis and why we think federal law would preempt state law on that issue. Any quick questions on that case study on APOT in California? Okay, our fourth barrier is the structural and political barriers to efficient system design. And I mentioned at the very beginning that statutes are, I mean, we know there's the two things you don't ever want to see get made are laws and sausage, right? So in the political environment, which we can't ignore that we are a part of, those statutes are going to be the product of special interests and lobbyists and moneyed interests and others who will want to shape those statutes to best meet their economic goals or protectionist goals or whatever they are, okay? And some of these laws blatantly, nakedly reflect political preferences and not evidence-based system choices, okay? Back to California, ladies and gentlemen. That's why we started this program at 9 o'clock Eastern Time. We knew many of them would not be tuned in. No, just kidding. We welcome our folks from California here, but I've said this in conferences in California on multiple occasions. So I'm not talking behind your back, California. One example is the California CPTAD law, community paramedicine / triage to alternate destination. Two of the big pieces of alternative modalities that Matt Zavatsky talked about. This is codified. Here are the statutory references. When you first read it, it appears to support innovation because it deals with the rollout of these kinds of alternative modalities. All of that is great. Matt talked about what these community paramedicine going to alternate destinations and stuff entails. All of this is great because it can reduce unnecessary emergency department utilization, improve patient-centered decision-making, increase system sustainability, which is our theme here today. But the statute includes a couple of key political accommodations, system failures, in my opinion. The local EMS agency, and that is the local EMS regulatory body. In Pennsylvania, we'd call it an EMS council. They call it a local EMS agency or a LEMSA. We have a company in South Central Pennsylvania called LEMSA, but that's the type of agency in California that regulates local EMS practice. The local EMS agency shall not include the provision of community paramedic program or triage to alternate destination programs as part of an existing ambulance contract in your area. Okay? This means that it limits the decision makers who are sitting down and writing EMS system plans from incorporating these modalities into the services that the existing contracted ambulance providers furnish within their systems. Okay? And the reason it does that is because of the second key limitation, that before any local agency puts these modalities in place, it shall first provide a first right of refusal to the public agency or agencies who have jurisdiction in the proposed area to provide these specialties before anybody else gets the chance to do them. Folks, who are we talking about in this statute? Public agencies. Fire departments, okay? So this accommodation was written into the law as a political preference to keep largely union-based fire agencies from being cut out of EMS systems, which is an important goal if you are a union-driven. No problem with unions, but this is job protectionism, okay? This is, we want to be able to play with our toys, not necessarily is this the best system configuration, okay? Now, California has a very different type, something that's unique that we do not have here in Pennsylvania and in most other states, and that is their statute permits local agencies and counties to specifically grant exclusive operating areas to ambulance companies that enter into a contract. And usually they decide who that exclusive provider gets to be by writing a request for proposals. And then interested ambulance companies, whether they're public or private, bid on those RFPs, and the prevailing bidder is then the exclusive provider in that system, usually for a period of 10 years. So it can be lucrative, And there is a lot of benefit to concentrating exclusivity in one company, right, for economies of scale and other reasons. But this law prevents the system designers from incorporating those modalities into those RFPs for the reason that we've visited here in these statutes, okay? So this is just, again, straight out economic and job protectionism for one particular constituency of EMS. And this is not pro-fire, anti-fire, pro-public, anti-public, pro-private, anti-private. There are public agencies, fire-based agencies, private companies, nonprofit, hospital-based, that all do a great job in running EMS systems. This is not pro or against. What this is that this ties the hands of system designers to develop an integrated system that makes these modalities that Matt was talking about a seamless part of an EMS system design, right? Because we are protecting one particular class of providers or one particular class of agencies, okay? So that political preference becomes an impediment to logical system decision making. And these slides talk about that. Now, a small bright spot is that the law sunsets every 5 years, but we would think that the same political forces that led that law to be passed initially would still be aligned 5 years from now, if not stronger, when the law comes up for reconsideration. So this is a repeating legal pattern, right? These 4 categories: transport, default over clinical discretion, context of where you practice over clinical competence, documentation, for example, over flow, provider type over outcomes, right? These are all essentially legally limiting factors that at the state and local level we have to be mindful of, because that is the legal infrastructure. So these laws were shaped by a long-standing tradition of what EMS is, political accommodations, economic protectionism. This matters because these transformations can't wait because of all the reasons we've talked about. Non-reform risks stagnation. Modern EMS laws should enable more clinical discretion, follow the evidence, support clinical integration, be outcome-driven, right? It should recognize that EMS is mobile health care. And I talked a little bit about how all of our clinical practice should be called paramedicine. Should EMS even be called EMS anymore? It's part of our identity, but does that help to fuel the public perceptions that speed is still the measure of quality? It's right in your name. What the hell took you so long? It's right on the side of your truck, right? If we took the lights and sirens off and rebranded and showed up in a nondescript minivan with a white coat and a stethoscope hanging around our neck, wow, it only took you 2 hours to get here and a clinical caregiver came, right? Think of how the public's expectations and demands of what we would do would change. And if we want to decouple payment from transport and be recognized for clinical care, we need to rebrand ourselves as mobile health care, because that is what we do. We're part of public safety in some cities, but we are healthcare providers. And if we don't embrace that fundamental labeling of our profession, don't expect the payers to just go, oh, okay, we'll decouple payment from transport. We have to make the case for clinical care and clinical excellence, okay? Those statutes, those rules have to incorporate competency-based frameworks. We have to sort of limit that operational control that hospitals can exert. We got to be outcome-driven. Performance has to be clinically based, not speed-based, right? Not based on employment status or geolocation or any of those other things. I want to put in a word that all states should adopt the Interstate EMS Personnel Licensure Compact, called Replica. Now, about half the states have adopted it. Pennsylvania is a replica state. Some of our neighboring states are not, but all states should join the compact. And a little just aside here is that we have done a lot of work with some of the companies Matt was talking about that have evolved into the telehealth and mobile healthcare space, non-traditional EMS employers. And in some states, we have found direct physician delegation pathways outside of the EMS system that allow EMS clinicians to practice under that delegated physician authority. Pennsylvania's Medical Practice Act has a general physician delegation provision in it, not to give orders to EMTs and paramedics, but to delegate medical tasks to anyone they think is competent to provide it. If you happen to be an EMT or paramedic, great, but if the physician is convinced that you're competent to do it, Medical Practice Acts allow that kind of delegation in non-EMS environments. We can build on and use those laws as we have in some states, counseling clients in those non-traditional environments. All of this requires collaboration between all of these stakeholder groups. If we don't do it, we risk stagnation, but if we do it, we can lead the way toward transformation that Matt talked about. So I left all of 2 minutes for any additional questions, but does anyone have any questions or comments?
So I'm just following up. Simple question was, Matt was very clean about the decision for the acuity of a patient and its EMD dispatch process. And so the goal is the decision should never be made at the level of acuity by the providers. It should be done at a PSAP or some kind of product like that. So what legal barriers to EMD would a county face? Should they, I mean, you had mentioned that the system, your dispatch centers would be willing to adopt this kind of triage and assessment. We've had unofficial conversations with our county and not so much. So the simple question would be, what are to alleviate my public safety directors, what legal concerns for a tiered medical dispatch EMD, even though they're EMD dispatchers, they actually don't do EMD structure. Have you seen legal concerns there?
Yeah, so what that question really raises is that unfortunately most legal counsel who are advising most 911 center directors, at least in Pennsylvania and in many other states, isn't Doug and Matt and Steve and Christy and Scott and Ryan. It's county solicitors who are really good at eminent domain and property law and employment law and that kind of stuff. And when they're the ones who say, if we don't send an ambulance, lights and sirens to every 911 call, we're going to get our ass suit off. And the 911 center director goes, okay, right? That is a hidden, sometimes not so hidden, system impediment. And I can't tell you how many rooms I've sat in where I've heard county solicitors say that, right? Show me. I'll wait. Go get the case law, line it up, show me where 911 centers, who enjoy limited immunity anyway in Pennsylvania, right, are getting sued or getting sued successfully for doing these patient-centered, evidence-based modalities. The guy who invented or first developed EMD, Dr. Jeff Clausen, always for years said at his conference lectures, no EMS dispatch system has ever been successfully sued for implementing EMD protocols and following them faithfully. I don't know if that's true still, but I don't know of any, right? So I would say the proof is in the lack of litigation experience and sizable damages, but now I'm the guy trying to prove the negative. Tell me I won't ever get sued. If that's your standard for liability and we're not going to do things because you can't prove that I won't, we will never innovate. So when people flip the script and put us in the position of having to prove the negative, we're already losing the fight. So we have to educate them that there is safety, there is liability protection, there is patient-centeredness, there is evidence-based deployment when we do those things. And if your model is we better send everybody hot to everything or we're going to get our ass sued off, that's going to invite liability. You think a plaintiff's attorney isn't going to read some of our stuff and go, do you mean to tell me that ambulance took 20 minutes because it was waiting in a hospital with a low acuity patient for 2 hours? Or because it got into an accident running with lights and sirens trying to get here, right? So those are going to be the liability risks going forward. So that's how I flip it. So anyway, thank you for raising that. Folks, it is now time for lunch. I think that there are box lunches outside, yes? Outside the room. We have till 12 o'clock. grab a lunch. If you care to eat while we're starting again at noon, feel free, but enjoy lunch, and we'll start again at the top of the hour. Thank you. Started again. Here, welcome again to everybody online joining us from all over the country. And I hope you enjoyed your brief lunch break. Again, keep eating if you're here in the room and haven't finished your lunch. Feel free to just keep munching away. So now I get the privilege of introducing my longtime friend and partner and co-founder law partner.
Thank you.
Not that there's anything wrong. In all of the business ventures that we've started, not only Page, Wolfberg, and Worth 26 years ago next week, wow. But PWW Advisory Group and the National Academy of Ambulance Compliance and all the business ventures we've done together. And, it's weird when you work with somebody for so long and you've been friends for even longer and you see that person become a legend and you always knew them as Steve. But
you're too kind.
But he is a legend, and in fact, he has just been recognized as such, as a legend of EMS in Western Pennsylvania, and will be honored and inducted into that group in May of this year. So the legend title is now official, and it's well deserved.
Well, just
for someone like Steve.
You're too kind. We also have two other legends in here, Eric and Ed. So they're also legends.
That's true.
Western
Yes, we do have
EMS. So
other legends.
I was going to say, I'm joining an esteemed group.
So let me read the prepared bio here and just give you some context about this legendary career. Steve is a fellow founding partner of PWW and our other enterprises, as I mentioned. And Steve got his start in EMS as a young teenager in north central Pennsylvania. Some of the same stomping grounds that I came from when I was a young EMS provider starting out in Pennsylvania. In his case, it was a small rural fire company in a beautiful place called Nippenose Valley up in Lycoming County. He became a certified EMT at age 16 and was one of central Pennsylvania's first paramedics, graduating from the August Williamsport Hospital paramedic program in 1979. After serving as a paramedic instructor and ultimately as assistant director of education at that program, Steve was recruited up to Erie, Pennsylvania in the mid-'80s to help start and then run a unique and innovative joint venture between the competing hospitals at the time in Erie and the city of Erie after the system there had collapsed. That collaborative venture, called EmergiCare, is now one of the largest nonprofit ambulance services in the Commonwealth. And after 9 years at EmergiCare, for some reason, Steve was encouraged to go to law school, where he graduated cum laude from Duquesne University in Pittsburgh, a fact we will not hold against him here at Widener, and became an attorney in 1994. I have to say, this is a little-known piece of PWW history, but so Steve went to law school 2 years before I did. I graduated from here in 1996. And when Steve left EmergiCare, he brought me up, recommended that I interview for his job as chief operating officer at EmergiCare. So Steve interviewed me for that job, which I didn't get, by the way.
Thank goodness. Thank goodness.
No knock on Erie, but my wife at the time when we were driving up for the second interview looked around Erie and said, yeah, no, that's just not going to happen.
I moved there in February.
I can't imagine that. But so just as well, I didn't get that position. But so it was fun being interviewed by Steve Worth, who asked me one of the best questions that I'll never forget in that interview. What was the last book you read? Yeah. And trying to sound pithy and erudite, I said Miracle at Philadelphia by Catherine Drinker Bowen, about which was coincidentally the last book I had read before my interview. And we talked a lot about that in the Constitutional Convention. Anyway, after a few years of working at some big law firms and seeing the need for a legal specialty that focused on EMS, Steve and I got together with the late Jim Page and started PWW, as I said, 26 years ago next week on the 20th. The rest is EMS law history. Steve currently works with all types of EMS fire and mobile healthcare agencies, both across the state and across the nation, in a wide range of legal, operational, workplace, and compliance issues. He brings a very pragmatic and very people-oriented and business-focused perspective to his diverse legal and consulting practice. I once said about you, Steve, you may or may not remember, that Steve is one of the great humanists in our profession, and I think you'll hear why here in just a moment. He's a sought-after speaker for regional, state, national conferences and presents practical information and strategies for seizing the many opportunities available to us during this time of great change in EMS and mobile health care. Ladies and gentlemen, my dear friend and colleague, Steve Worth.
Gosh, thank you. Wow. Boy, that took up half the time. No, just kidding. This is great. And there aren't many, I don't know of another law practice where the partners who founded it are still working together after 26 years. So I think that's a testament to what we've accomplished as friends and colleagues and with the great team that we have. But another little story about Doug Wolfberg now that I'll have to share is Dean Cummings in here. But when Doug and I talked a lot as he was gearing up to go to law school, and it was a very competitive time. For me, it took me 2 years to get into law school, and I ended up at Duquesne. I was going to go to Temple. But Doug was accepted to 2 places at least, one of which was a New England law school, which I don't remember the name of, and the other was Widener, which was pretty new back then, just a couple years old. And he was kind of leaning toward the New England law school. He said, which one do you think I should go to? And I said, Widener, of course. Widener, where you have all your connections and everybody knows you. So I don't know if that made a difference. Okay, there you go. So, and the fact we didn't, Emergent Care didn't hire you, we wouldn't be here today. So it's great to be here with some, some folks that I've known for many, many decades. This certainly is the epitome of EMS folks are not wallflowers, based on what we heard this morning. Everybody's talking and engaged. That's great, because you all have great insight to what's going on. I was really encouraged when the question was asked, how many of you have been involved in EMS more than 20 years? And like 90% of the hands went up, okay? I'm sure out there in webland as well. But, so actually I've been doing this for more than 40 years, okay? Just finished 50 years of continuous certification. But here's the deal. If you've been in EMS more than 40 years, you basically don't say the exact number. You just say 40-some years, okay? Keep them guessing, so to speak. Talk about innovation. That's what we're talking about here today. We've heard a lot this morning about innovation in technology, innovation now in system design and how we're operating our systems. This here is the epitome of innovation. This is 46 years ago. This thing was the cat's meow right here, the LifePak 5. You all remember that? Hell, that damn good monitor defibrillator. You can take it apart. Then, of course, we had this. Anybody still use these? This, by the way, is a wire attached to the transmitter receiver, okay? The AppCore radio, remember those? How many used them back in the day? Okay, there's a few of you here. That's great. And then, of course, we got the unwieldy 80-pound drug box, and, of course, the nurse overseeing everything we do. So things have changed a lot. But what's really interesting about EMS is we've been really good at innovation when it comes to equipment, right? All the LifePaks, defibrillators, all the latest stuff, technologically sound. We're off the charts, man, in terms of leading the way for innovation in equipment and technology. Not so much in system design. We're still doing things the old way, as we talked about this morning, with our design and with our people. And that's kind of what we're going to get into here this afternoon a little bit for the next 45 minutes or so. And already we've heard some comments from the audience about some of those issues. So, yeah. Oh, well, the guy with the comb over, because I was losing my hair at age 16. So the guy in the back, The far right, okay, that is me. Yeah, I guess so. Okay, so yeah, that qualifies me to be an EMS artifact. And like many of you, and in fact, Saturday morning, Doug and I are going to go back up to Williamsport because we gathered a bunch of the 25 or so EMS artifacts that we've worked with way back when. I think we're calling it the Well-Worn Williamsport Whacker Breakfast. Yeah, that's the name of that. So anyway, it's great. Here's what we're going to talk about. And again, interrupt, throw out comments as we go along. let's put things into context. I like to step back a minute, look at the big picture. Why do we have these problems? Why is it that we have paramedics, as Dr. Bledsoe said, they don't want to engage the patient? You know, do you really need us here? You don't really need us here, do you? You know, that kind of thing. What's going on out there? What do paramedics really want? What are the issues that they're seeing through their eyes in terms of what they expect? Because all of this, if you haven't figured it out, folks, this is all about expectations. Expectations of the public, expectations of our elected officials, the expectations of our people, of the patients they serve. This is what it's all about. So we'll talk about the problem in the context of staffing and the people side of things. Then I want to hit on the foundational 4 C's. These are the 4 C words that I think we really have to work on to ensure ultimate success in this transformative process that we're going through. And then lastly, wrap it up with some action steps for you. All right, let's take a look at it from the standpoint of stepping back a minute, putting things in context. And I love this slide because we are hard-driving type A personalities. We focus in on the patient. We focus in on a problem. Sometimes when we focus in, we lose peripheral vision, right? We don't see the things coming at us from different angles. And I love this because people up here are looking at this, they don't know what the hell that is, but if you step back, you know, instead of just a black area, you see an elephant. And that's what we all have to do as leaders. We really need to step back, say, what's the root cause of what's going on here and why do we have some of these problems? So, gave some thought to this, obviously, and you know, here we go. What's the situation out here? It's been tough out there. The last 6 years have been the worst 6 years for our people in EMS, hands down. I think everybody would agree with that. And it's not just COVID. We had a double whammy. We had COVID, and then what happened right after COVID? The George Floyd case. We had civil unrest. We had a lot of visuals on social media of law enforcement, prone restraints, pulling people here and there. Gee, we're seeing some of that even today. We have engaged in a very difficult time period in this country of a lot of incivility, okay? Civil unrest. That affects us because the public, the average citizen, certainly look at not just law enforcement, but anybody in uniform with a jaded eye, okay? That's the reality of it. So we got hit with that double whammy. Increased call volumes. Is anybody's call volumes gone down in the last 5 years? No, okay? Gee whiz, what kinds of patients are we seeing now? More non-acute patients, as we've been talking about, and more system, I don't like to call them abusers, because in many respects, they don't know any better. They don't know who to call, which is kind of a compliment to us and the fractured healthcare system that we're all operating under, because there's one part of the healthcare system that people have come to rely on 365, 24/7, and guess who that is? You all. So it's a compliment in a way that they call us. They're misusers sometimes, not abusers necessarily. Oh yeah, there's a few of those, but most of the time people don't know what to do, and we got to work on that. And then we've got inadequate reimbursement and system design issues, which is, you know, what Matt has been talking about at the initial session and as Doug dealt with as well. So we got a bunch of things. These are affecting our people, and these are some of the headlines. We're also dealing not just with those issues that are affecting us, our people, and our organizations. We're dealing with a whole new workforce, right? What do you think of the new workforce, folks? Do they have a high work ethic? Do they really, come on, what can I do next kind of attitude? Hell no, okay? But it's not just the young people. It's also older people, because it's ironic, the litigation we see for negligence and that kind of stuff, it has no specific age group. That goes across the board. But these are the things we're seeing. We're seeing a divided nation, incivility, and people are not happy. There's been a lot of studies coming out about happiness. In today's society, we're not as happy as we were 20 years ago. So that ties into the foundation of the issues we're dealing with. So we have lots of incivility. It's affecting medical performance. There's studies and research that backs this up, folks. That's that last headline there. We're starting to see some of the research coming out on how incivility and communications issues are affecting how we deal with people. Now, this is part of the problem, and I call it the Gator medic syndrome. And that is, we're not being as empathetic and as compassionate as we should be. We have seen an uptick in complaints, in dealing with investigations, lawsuits, you name it, personnel issues, because we handle a lot of that, where the bottom line is the provider, the clinician, they weren't nice to the patient. They weren't kind. They didn't talk to them, okay? And that's the kind of stuff that gets you in trouble, like that video clip that Doug showed you. You know, this is the kind of stuff that is affecting our reputation, and it's affecting the culture of our entire organization. And yes, we have these headlines: the lazy medic, striking a handcuffed patient, assaulting a patient, improperly giving medications, pronouncing someone dead who wakes up in the morgue in a body bag. What the heck? How can that possibly happen? A young female who just had a baby, and they didn't recognize that she had a stroke. They thought she was drunk, and she died, and they convinced her she didn't need to go to the hospital. That type of thing. So we're starting to see more and more of these kinds of headlines. So it sort of begs the question, what's the root cause? And we sort of alluded to some of them. Y'all remember the Titanic, 110 years ago or so? What caused the Titanic to sink? What was it? What happened to the Titanic that made it sink? What is it? They hit an iceberg, right? Yes, they hit an iceberg. Physically, that's what caused the Titanic to sink. But is that truly what caused the Titanic to sink in the sense of what led up to that? And what did you have? What was the problem? Not enough lifeboats. You had a captain asleep at the switch on his last voyage, more interested in spending time with the rich passengers. You had an ill-trained crew. You didn't have procedures. You had a boat, an attitude that we're unsinkable. Talk about culture. The culture of that whole process was, we're not going to sink, we can't sink, okay? The walls between the compartments only went 3/4 of the way up instead of all the way up, so when the ship started to go one way down, it just cascaded and broke in half and sunk. Yeah. Now, the sad irony of that is, you know, a lot of people died, a lot of people were saved, okay, fortunately. But if that were to happen today, what would the Titanic sinking look like? That's what it would look like, right there. Our narcissistic society, people are so interested in getting on social media. That is their thing. The hell with everybody drowning behind us. Oh, Jack, let's get a selfie before I push you in. Hey, I like evidence-based stuff, right? Isn't that the buzz phrase? Mr. Evidence-Based back there, Matt, my good friend and colleague. Here's some evidence, some background research. 2014, the children we mean to raise, the real messages adults are sending about values. 2/3 of our youth feel that their parents do not value caring for others as much as they value achievements and accolades. Does that have anything to do with today's society? 2016, fully 1/3 of all Americans do not even consider compassion for others as one of their core values. Wow, that's a problem, and we wonder why we have clinicians who aren't compassionate, okay? It really comes down to your people. They are the key to success in everything we do, and not only are they the most significant cost center, but they're the people front and center with the patients, performing our mission, helping people, okay? And the bottom line is, all the lawsuits, litigation, everything comes down to how we treat other people. And most lawsuits in EMS are not based on negligence. Oh, yes, they sue you for negligence because that's how they get their foot in the door in the courtroom. They can't sue you for lack of communications issues. They sue for negligence, but that negligence in the vast majority of the cases is based on lack of communications, lack of compassion, and instances of disrespect and inattention. Now, how do I back that up? Go back to studies that came out 25 years ago. In basically 70% of all malpractice depositions, these were the key things, and they all relate to attitude and communication skills. Deserting the patient, not spending time with them, devaluing their views, not listening to the patient, delivering information poorly. Gee, how do we do that today? Ever go to your doctor's office lately? What's the doctor doing? Is the doctor looking at you and assessing you? What are they looking at? The keyboard. They'll tell me about that. They're not even looking at you. I just saw a doctor for a back issue, and he's an older guy, kind of like me. As the interview started, he pulled out his phone. He said, "Steve, I just want to let you know that I'm going to set this phone here. Now, this has a program that's going to record everything and complete notes for me. And if you don't mind, I'd like to record this session." He threw it down. Then he stood in front of me and talked to me and assessed me, and we talked. And that was the advent of AI in the doctor's office, okay? He had a report printed out within half an hour after that visit. I asked him, we spent 10 minutes, he spent an hour with me, 10 minutes talking about that. He says it saves him 2 to 3 hours a day. So there's an area where, think about this. We think technology is bad, AI. That's where AI and people come together. That's a tool that can help us spend more time with people. But these issues, delivering information poorly, failing to understand the patient's perspectives, this has been going on for a long time. This is 1994 study of litigation cases in healthcare. This one recently, safety experts investigated 23,000 med malpractice lawsuits, found more than 7,000 of those lawsuits could be attributed to communication failures. Those failures resulted in $17 billion with a B in malpractice costs, almost 2,000 preventable deaths. Gee, that tells you right there. How can we save lives? Not so much with what we do with our skills, but being nice to people and communicating effectively and getting to understand what's going on with them. What do EMS clinicians really want? Okay, we need to look at that from their perspective. Fitch and Associates with EMS One Magazine and Pulsera, they've been doing this What Paramedics Want survey for the last 5 or 6 years. And what they're finding is in the recent studies, I'm just pulling some of the recent surveys, these are thousands of EMS clinicians surveyed around the country. When it came to retention, poor leadership cited 7 out of 10 times, 72% having an impact on retaining quality people. Our leadership feels threatened by anyone with more experience that offers solid ideas to assist them with their duties. Ooh, there's a big leadership culture problem right there. Most of our leadership do not have the qualifications to hold their positions and lack the personality to be positive influences on the system. Leading causes of stress for our EMS clinicians. It's not the lack of pay, although that is a serious concern. We can't dismiss that. But when you ask them, what's the big issue? Lousy leadership. My direct supervisor. People don't leave organizations, by the way. They leave their supervisor, okay? Somebody who's a difficult person. Personnel management, staffing problems, yeah, salaries in there as well. And over the last few years, we look and we see last survey done, burnout jumped to the very top, which says we need to do some work in that area. And we'll talk about that as a strategy in this transformative workforce that we're dealing with. And you all remember Maslow's hierarchy of needs? Well, there's the 2 added pieces to that pyramid now. Got to have Wi-Fi and battery, right? That's today's workforce. And what's the perception of leadership? From the standpoint of leadership, and I saw some heads nodding when I asked about the work ethic in today, a lot of leaders today say, Gen Z, they're toxic for companies. They're terrible. They don't want to work. They're lazy. So, but then you talk to Gen Z people who are working and they have a different perspective, a totally different perspective. So there's a lot of disconnect between leadership and the frontline workers in today's healthcare world, including ours. Well, there you have it, the millennial generation and Gen Z. That's 52% of your workforce or more right now. So think about that. I'm a tail end baby boomer. Now, Ryan, which one are you again? I think you're Gen X, aren't you? You're like in the middle? You want to admit that you're a Gen X? Okay, Ryan's Gen X. Even Ryan's old, okay? From the standpoint of the workforce now, okay? Because the main core of our workforce are the younger people now, okay? Gen Y, Gen Z, and if you're interested, it's now we've run out of names, so it's alpha, beta, for the coming ones. And what does Gen Z want? Well, ironically, they're very social, they're entrepreneurial, they're very concerned about the world, economy, and environment, okay? They're interactive, they're digital natives, they grew up with, cell phones and smartphones, and the problem with that then is they're not as focused as, others may be. They're very cautious, they actually save money. My son is tighter than the hinges to the gates of hell. He don't want to spend a nickel on anything, okay? But this is the big problem. What is the big problem that you have to deal with when you educate your new workforce? That's the hint. The attention span. They have the attention span of a gnat. That's a gnat, okay? Seriously, we're talking about people who have an attention span of seconds that we're dealing with. And we've got an expectations problem with our people. And we've got to address that as we move forward with this transformation. This is what we've been telling our people for years. We're going to train you to save lives, right? Save lives with sophisticated medical equipment, cutting edge, life packs, defibrillator, and your skills and medications equipment, life-saving interventions, right? That's what we call them. We resuscitate, ventilate, auscultate, medicate, defibrillate, intubate, whatever ate, okay? Those are the life-saving interventions. What percentage of the time do we engage and use those interventions on a patient? Matt? See, he's even got it down to the decimal, 6.9%. So what are we doing the rest of the time? What kind of services are we providing? What skills are we bringing to the patient if we're not using these life-saving interventions? What are we doing or should be doing? Anybody? Communicating, listening to them, being kind to them, or simply just holding their hand and showing some empathy and compassion toward them. Yeah, be nice, communicate. Yeah, because today's patients, we know, more non-acute patients, yeah, they're dying all right. You can save lives. They're dying to know what sandwiches are serving at the ER tonight, okay? And that's why they got to get there. But we have this big disconnect, and that's our problem. We created this. The expectation is you're going to go out there, and it's emergency medical services, lights and sirens, all that, save lives with all your ALS interventions and what have you. But the reality is the opposite. We're not seeing as many of those. They're fewer and far between. So our sense of immediate value or immediate gratification, if you will, for what we do is a little attenuated now because we're dealing with non-acute patients, chronic patients, patients who don't necessarily need those interventions. So that leads to frustration, apathy, compassion, fatigue, burnout. How much time do we spend in EMT and paramedic school on how to communicate with patients? How much time do we spend in EMT and paramedic school on how to deal with elderly patients? How much time do we spend on that? Practically none, because we don't have the time to do it. We got to train these folks to do those life-saving things, and we figure they'll get the rest of that later. But what's later? That's our responsibility. And you all know from onboarding your people, you got people with a whole wide range of skill sets and communications abilities. I've heard many of you say to me, it's like starting from scratch. Did they even go through a program? When they talk to people, they're looking down at their phone, So we need to work on that. Our good friend Andy Lovell, who runs EMS over in Gloucester County, Gloucester, I think I pronounced that correctly, New Jersey, when he onboards his people, he's got one sheet of paper, one piece of paper, and he spends all day on it. And that's it. Not a policy, protocol book, SOG manual. It's one piece of paper titled Andy's Expectations, and number one on the list that he spends an hour or so on is that patients and incident responses are not an interruption of our day. They are the reason we exist. Well, of course, duh. But do you have to remind your people of that? Yes, we do. We have to constantly remind them of that, and that's part of the issue. Now, the legal landscape. I'm not going to spend a lot of detailed time on that, but just to debunk some of the, vitriol that we see in the news feeds and everything else about DEI and other things, the reality is, yes, the current administration has issued some orders, okay? We're going to retire the Equal Employment Opportunity Commission guidance on protecting LGBTQ workers, okay? There's other things that have been done. But at the end of the day, folks, despite these massive executive orders that went out January 20th, a year ago, the federal and state laws have not changed. You've got to ensure a non-discriminatory workplace, regardless of somebody's gender, sexual identity, sexual orientation, what do you want to call it? That's still prohibited. Okay, all those protected characteristics, we got to make sure we are inclusive in the workplace because that's the law, okay? Despite the things you may hear about these things being rescinded, that is the law. So the best advice in going forward in transforming our systems is treat everyone with respect, fairness, dignity, all right? Employment decisions should not be based on any of these things here, age, race, sex, religion, national origin, sexual origin, gender identity, et cetera, or any other protected class. So we need to focus on that. Now here's the 4 foundational C's that I think we need to really emphasize as we make these changes. Because, hey, we got all the evidence to make these changes. Guess what? You got to sell them. You got to sell them with your elected officials. And guess what they still think the number one thing they should look to evaluate the effectiveness of EMS is, speed, okay? We got to educate them. We got to educate our people that it's just as valuable to take care of an elderly person going from a nursing home to the hospital as it is somebody who needs an IV and medications, okay? We got to work on that. So here's the 4 C's. We got to provide competent care. To me, that's the easiest one because that's skill-oriented, which is what the EMT and paramedic schools do so well at, competent care. But we have to teach and engage communicative care. We got to have people who can talk to each other, okay, who know how to communicate effectively with other human beings. And we know that's a challenge in today's world of smartphones, so-called smartphones. Collaborative care. As you heard this morning, everything is coming together. We're all working together with the hospital systems, with everybody. We have to be collaborative with everybody that we work with in the system. It's not an us versus them situation. It's we all got to work together to make it best for the patient. And then lastly is compassionate care, which I'll explain the difference between empathy and compassion in a moment. Competent care, as we said, the easiest one, I think, of the 4 foundational things. Do we check our people out? Do we make sure they're good people? Do we check their references? A lot of places don't anymore. In fact, it's kind of a running joke. You get fired at this ambulance service, you can run across the county and get hired by this other one, okay? You guys are smiling, you know that, okay? Do we properly onboard people? Oh, we're short-staffed, we got to get a body in the seat, okay? So we're going to cut short your onboarding, okay? We need to focus on that. How do we evaluate clinical competency? Are we even doing that? Do we have supervisors that actually go out and watch their people work? Or as one supervisor told me not long ago when I asked him what he actually did on the job, he said, as he's sitting there at his desk in front of the computer, he says, I'm just a scheduler. I'm just a scheduler. I mean, you don't go out and watch your people and help them? No, I don't have time for that. Okay? How do we handle medical errors and untoward events? Do we have a just culture for that? If somebody forgets to put somebody on oxygen who needed it, and they didn't do that, is that going to become a disciplinary matter, or is it an educational thing? In some states, I've seen that particular issue being driven to the state EMS office for an investigation and then ultimately some penalty against the person's certification. Is that the way to handle it? I don't think so. Do we keep up with the new modalities of care? Are we getting our people involved and recognize treatment in place? Are there differences in how we handle patients in that situation versus somebody we take to the hospital in the ambulance? Yeah, because we're going to leave them there. We got to look at other things. What about safety issues around the home? Are they able to manage the situation after we leave? Telehealth. Now we got other healthcare professionals on the line, so to speak. How's that interaction go with us, that new healthcare professional, and the patient? And how do we document that? And now we got increased interfacility transports. How many of you are experiencing an increase in interfacility transports? Just raise your hand. I'm curious. Seeing more of those? Seeing some hands go up. Well, guess what? Our healthcare system is now beginning to operate like the airline industry, right? The hub and the spokes. And a lot of hospitals that used to do a bunch of stuff out here at the end of these spokes, they're not doing it anymore. So what happens when the patient gets there? Where do they go? To the mothership, to the hub. Gee, have we adequately prepared for that? These long distance transfers? Have we adequately prepared our people for this kind of thing? Critical patients in the back of our ambulance, okay? No, we haven't done as well as we should. What about mental health and other difficult patients, elderly patients, pediatric patients? We're seeing an increased number of sicker infant and pediatric patients these days as well. We're going to see more of that as less people are on the Medicaid rolls, as we're going to see. We're going to see these situations where people are going to be sicker because they don't have access to health care. Communicative care. This is all common sense stuff. You all know this, okay? I'm not giving you any new information here. But we got to remind people that it's all about our initial approach and the impression we make in the first 30 seconds, okay? In the first 30 seconds, the patient's going to decide whether you're a competent person or not, whether you're somebody they want to take care of you. They're going to do it in 30 seconds. And what's happening now? Well, I'm telling you, everywhere I go, I run this little scenario of this non-emergent elderly person who's on the, cut his head and he's conscious and alert and he seems okay, and the EMS crew walks up to him, and what's the first question out of the box? Do you want to go to the hospital? Were we taught that be the first question out of the box? No. It was, hi, I'm Steve. I'm a paramedic. I'm here to help you. What seems to be the problem? Looks like you cut your head. Doug? Damn good to meet you. Yeah. We don't do that initial confident approach. And that question, in fact, it's even worse than that. It's, do you want to go to the hospital or not? In other words, you better don't want to go to the hospital, or, I'm going to be mad at you, kind of thing. So friendly introduction, sincere concern and empathy, acting like you want to be there, active listening skills, nonverbal skills, communicating with the family. A lot of complaints come from family members who say they didn't listen to me, they weren't nice, they were rude. Don't be talking about what you're doing at the end of the shift, on the scene. Smile. Okay, I have trouble with that. I got to forcefully smile, but smile to the patient. That's positive. It also releases some endorphins in our own brains when we smile. We feel good. And say goodbye to the patient. Tell them they're in good hands, even if they're waiting in the hallway, and wish them well, because that leaves a good impression with them. So good first impression, good last impression. And the risk management benefit of that is if you're nice to them up front and you're nice to them at the end, and screw up in the middle and they'll forget that. They won't remember that. Okay, but that's a way to make a good impression. Written communications, we got to have good patient care reports. We know we all struggle with that. We did a national documentation survey this past year. We found a big disconnect there. Lots of issues. That's something we need to work on because we're creating a medical record here for the patient. And our documentation is just as important as anybody else's in the system. Collaborative care, we work with diverse professionals, as we know. We got to be cooperative in all aspects of working with others. None of this should be a barrier. There should be no barriers to communications
about patient care. When the hospital says, I can't tell you that because of HIPAA, that isn't right, okay? We need to work on that, and we need to educate and meet with folks ahead of time. We need to be adaptive to the new things that are happening. Telehealth is here. We know that. That brings us some challenges from the standpoint of interaction at the scene, as well as documentation of that care, that telehealth visit. And we're seeing more advanced practice providers and clinicians today because of the higher acuity of patients in our facility. Kind of ironic, the acuity of the 911 patient is going down, but the acuity of the interfacility patients is going up. Huh, have we thought about it that way? We need to, because that's what's happening. Outpatient visits, hospital at home programs. You know, we're going to see patients with hospital beds in their living rooms, hooked up to IVs and all that. How are we going to deal with that? We need to work with our hospitals so that when we come and pick up the patient to take them to the mothership, okay, that the nurses and the other people, when you ask what's going on with the patient, they shouldn't be saying to you, I don't know, just get them out of here, okay? Because now you're dealing with the care of a patient who could go south pretty quickly. So we need to focus on that. Somebody said this earlier. EMS is no longer just emergency medical services, okay? I think Doug suggested it. The name's wrong, okay? And that's part of the culture and part of the mentality. But we're still high tech and high touch. So it's really both. And we got to lead in both categories, working collaboratively with others. And the last one is compassionate care. Empathy is the ability to appreciate someone else's feelings, okay? And look at a situation through their eyes, okay? But compassion is actually acting on that empathy. That's putting empathy into physical action, doing something for the patient that's beneficial to them. And the irony of it all is providing compassionate care is not only good for the patient, it's good for us as healthcare clinicians. We feel better about what we're doing as a result of administering compassionate care. It gives us the better ability to understand the patient's situation, their perspectives, their feelings. That's going to help in diagnosis and understanding their problem. Gives us the ability to communicate that understanding, check its accuracy, to ask, to paraphrase. So this chest pain, you said you think it might be related to your heart problem? Is that what you're telling me? You know, it gives you a chance to affirm information and allows us to act in an understanding way that's helpful and beneficial. And that means they're going to tell us more. They're going to talk to us more. They're going to tell us more about their symptoms so we don't miss something and leave somebody behind who needs to be transported. Better accuracy in all we do, getting more patient illness-specific information, and the patient gets more involved in their care with compassion. And ultimately, greater satisfaction. Patients are happier. They're more engaged in their health care, and it's going to reduce their emotional distress and hopefully improve their quality of life as well. And it's a cascading thing. And if you've got a culture of compassion in your organization, people are going to, in your organization, are going to be grateful for the opportunity to serve someone like this or someone who is not a critically injured or ill patient, okay? It's contagious. Let's start an epidemic if we want to start an epidemic. So that's the 4 foundational C's that I think are essential in our transformation. All right, so now I got 16, 17 minutes. I'm going to wrap up with 8 quick leadership action steps here in terms of preparing that workforce. And I think we'll have a few minutes left for questions at the end as well. Positive and supportive culture for change. That's sort of been the theme of everything we've been talking about today. And some organizations have done a really good job of this. Steve Grau, president of Royal Ambulance in California, big operation. He says this, and this is part of their mission. We may only be a BLS service. You've heard that many times. Well, I'm just an EMT. We're just BLS. And our scope of practice may be limited, but our ability to make our patients feel good is unlimited. I love that juxtaposing limited and unlimited in that quote from Steve Grau.
Paul Scarborough, president of Premier Ambulance. Our business has very little to do with our ambulances, equipment, or gurneys, but it has everything to do with the people providing care and interacting with patients and their families. And when people at the top of the organization are constantly talking about these things, that has an impact on the rest of the people. Hall Ambulance, the 3 C's. Care, providing the very best for our patients. Compassion, knowing that sometimes holding their hand is the best medical care we can give. Community, giving back and being an active part of the communities we serve. I love that slogan. We don't treat patients, we care for people. I forget who said that one. I couldn't attribute that to anybody in particular. Secondly, train everyone on positive communications and compassion skills. No question about it. Thankfully, all of us have the power to get better at this. This is a skill like any other skill. As long as we have a growth mindset, an open mind, and we're intentional about learning, we can all learn compassion, even those who aren't very compassionate, okay? We're all works in progress, as we know, but if we believe we can get better and we take steps to do that, we can get better. What about evaluating compassion factors when you do field evaluations? There are compassion checklists out there that can be used. Sim-based scenarios with virtual reality and augmented reality applications. Body-worn cameras, probably the best educational tool in the field where we can go back and look at the call. Gee, why did you talk to the patient that way? Okay. Why did you say that? Okay. Why did you say you don't really want to go to the hospital, do you? Okay. That is one example. A very powerful book, and I do a separate session entirely on this subject of compassionomics, but Stephen Terziak and Anthony Mezzarelli wrote Compassionomics, the revolutionary scientific evidence that caring makes a difference. It truly does. This is important as we transform our systems because compassion does all these things. Everything from mitigating pain, improving patient outcomes, reducing the likelihood of medical errors. All of this, all these positive things are grounded in research. All you got to do is read that book. And frankly, if you read that book, you'll be energized. You want to go out and start telling people about this, okay, and how important compassion can be. And yes, it's not only possible, it's actionable. This tremendous article by those same authors in Harvard Business Review 2 years ago is another, what I would say, must read based on the research. Third leadership strategy is to develop innovative training programs. We talked about the attention span of the gnat, okay? We got to work on that. How can we get messages to people, short, simple training that's 30 seconds long, 2 minutes long, so that we make the points that need to be made. And that's something we need to work on. There are evolving smartphone applications out there for training. There's a lot of stuff happening in this world. You all probably know more about it than I do in terms of some of these new innovations. And recent stuff is starting to come out in the research in terms of the negative impact that social media is having on young people. Not just young people, older people. I got an 87-year-old father-in-law who all he does sits there all day doing this, scrolling, watching Facebook reels. And you should see some of the reels he's looking at. I mean, it's numbing to the brain. It takes away our ability to interact with each other and look other people in the eye. This is a telling statement from somebody in this study. The study just came out. TikTok has made my attention span so low, I can't even watch a 1-minute video. That's our challenge in training. Okay, everybody, we're going to spend the day here, and Doug and Steve are going to click through the PowerPoints all day long. Young people just aren't going to get that. We got to implement 360 feedback. And this is challenging because it means we have to be vulnerable to feedback from the people who report to us in a paramilitary operation, I've actually been to ambulance companies where no one has a name. I said, well, what's your name? I'm lieutenant. What's your name? Oh, I'm captain. Oh, I'm assistant chief. They refer to each other by their titles. They're not allowed to call themselves by their first names. Are you kidding me? All right, that's a carryover of the things we've always done in the past. And yeah, that's important to just use titles at the scene of an accident and where people are trapped when we're dealing with human beings back at the station. No. 360-degree feedback. In other words, you stay in touch with everybody that's assigned to you, that you're responsible for, rather than, supervise. You're responsible for. You're responsible for your people. You should touch base with them every day. And they should be able to give you feedback as well. Here's a neat little program, Newton 360. It's all done on a smartphone. You can keep touch with everybody. And then if you got 40 people reporting to you, you can say, oh, gee, I forgot to talk to Doug and Ryan and Steve. Okay, they're on my list to talk to today. Okay? Important. 5, provide effective mental and physical health resources. Like we said, the last year's survey of what paramedics want, burnout came the number 1. I think that's a culmination of all those other factors for the last 6 years that I talked about. Okay? And it didn't get any better, so we got to work on that. Employee assistance programs, peer support programs, all of these things. Our friend Daniel Sundahl, right? Sundahl. This is not AI, by the way. This is actual artwork, okay? He lets us use it, okay? But that sort of is the epitome of what a lot of people feel after a call. And we need to deal with that, and we need to provide support. Anyone seen Code 3 yet? Great movie. Encourage you to see it. It's, okay, some of the scenarios are kind of extreme, but it's about a burned out paramedic on his last day of work. But in this movie, you all will laugh and can relate to every single one of those instances, okay? But you can also see the compassion and the advocacy for the patient that he exhibits in every single one of those scenarios. Great movie, okay? That's my opinion, okay? You may look at it differently. Some of the stuff's crazy. Yes, of course, they're running lights and sirens to everything, okay? So we still continue to emphasize that misnomer. Peer support programs I mentioned, that's very effective. These things work because now it's peer-to-peer. And I know Wake County has one. There's a lot of places in Pennsylvania that do them. I'm sure some of you are doing them, okay? Excellent, excellent, excellent way of combating occupational stress. Practice empathetic leadership. You can train your leaders on this stuff, okay? Do that. There's lots of people out there doing this kind of training. Train them on just simple emotional intelligence. You know what that is? It's not complicated. It means if somebody's talking to you, you actually listen to them and want to know what they have to say, instead of waiting for the very first time you can interrupt them so you can make your point, okay? That's emotional intelligence. Management by being there. One of the things I learned at Emergent Care, the thing that I thought helped me bring about change the most was riding along and having 3x5 index cards in my pocket. By the end of the shift, riding from call to call, I just was there to help. And I had a list, front and back, 10 cards of all the problems and complaints and concerns that were easy to address that I wasn't hearing at the top of the pyramid. Know your team as people and not just employees. Understand the frustrations and the stress they're dealing with off duty because they're working a hell of a lot of hours for you. We know that. Develop mentorship programs. A whole bunch of us in this room said we had more than 20-some years experience. That's 90% of this room. What are we doing about that to bring up the new leaders and train them? Some leaders say to me, well, why should we invest in our people? They're going to be gone in 3 years anyway, or 4 years. Well, so what? At least they go with a good impression and you help build and grow somebody. Mentorship programs, that's NAMT has it, AAA has it. They don't have to be as formal as that. You can do your own. Royal Ambulance, there's our vision. Our mission to positively impact the patient's journey, make our customers' jobs easier, and develop healthcare leaders. One of their principal of 3 missions is developing their people. In fact, they give them money because they want people to go out and become nurses and doctors and other healthcare. They want them to grow and develop because that's going to make them better people for the time that they have with them. Some closing thoughts on this. Yes, we have to remind everybody of this, but this is a very important thing. This is a big advantage we have over other jobs. When I was in my graduate program in Erie, I did a study on the job characteristics of EMS work. And what it found was based on scientists Hackman and Oldman. And they basically said that people get job satisfaction from the work itself, from the nature of that work. And that showed to be proven in my study, which was ultimately published, that this is inherently meaningful work, and people want this job because the job itself is good. Wow, that's a big plus, because there's a hell of a lot of other jobs that aren't as inherently valuable to society as some may think, okay? I think every job's important, but bottom line is our work is very inherently meaningful. And it's all about attitude, and how you present yourself in front of your people is absolutely critical. If you come into work and that's your partner for the day, you are in big trouble. Look at the look on that face, okay? That's not just a bad attitude look. That's like contempt, okay? Get away from me or I'm going to cut your head off, okay? Yeah, we do. Yeah, you do. You have cat. That's right. You see that, we have a golden retriever. We call him Petulant Piper. He has that pissed off look all the time. Attitude is everything. Life is 10% what's thrown at you, 90% how we react to it. And unfortunately, we're all very reactionary personalities, or we wouldn't be in this business, this hard-driving, life-saving business. We got to slow down and remember, don't jump to conclusions. Don't just react. Think about it, okay? And also, don't let it affect you. One of the things I learned, when I was working at emergency care in Erie, a lot of people complaining, you learn to let things go in one ear and out the other, and don't let them affect you personally. Sometimes we take things too personally in all aspects of our lives. So, bottom line is positive attitude and compassionate care leads to excellent patient care, excellent patient satisfaction, excellent documentation of that care, and as a side benefit, no lawsuits. And this is so, so very important as we move to transition our systems and transform them. We got to remember the people side of it. We got to remember the public side of it, as we talked about already this morning, and the challenge of educating the public that speed isn't the thing that measures the effectiveness of your system. Same thing with our people. We got to let them know what's happening and what skills are essential to what we do. Closing this with Jim Page's quote from a speech he gave right before he passed away called Saving Our Society. He gave it to a large group of paramedics and EMTs, and several hundred were in the room. And he said, there's a great power in small acts of human kindness amid social upheaval and barbarism. And you have the opportunity to exercise that power every single day. Now, when Doug and I uncovered this speech maybe 8 or 10 years ago, and I looked at those words and I thought, this was 10 years ago. Gee, Jim, using the phrase social upheaval and barbarism, that's pretty strong. Is right. Is it? In today's society, we're dealing with a lot of social upheaval and barbarism in today's civil world that we're living in, okay? Let's add a little kindness to it, is the point. He was a man ahead of his time. I think he saw what was coming when he used those words, which I thought was over the top when I found this speech 10 years ago. Today, they aren't over the top. So we remember that. The shirt. Matt Zavodsky, he's wearing this shirt. We were traveling, and I saw this shirt. I'm looking at the back, and it says, everyone you meet is fighting a battle you know nothing about. And I said, that's really cool. And on the front of it says, be kind. And that comes from a group called the Till Valhalla Project. It's probably a motorcycle group, isn't it? No? What's that? It's not. It's a military veterans group, and the funds that go from the sale of these shirts help them. So we got to remember that. It doesn't matter. All of us in this room, we've got battles we're all fighting, okay? That we know, the person next to you knows nothing about. Same thing with patients. We got to remember that and be considerate of that, okay? That homeless guy on the street that's intoxicated, hell, he could have been a successful engineer and lost his wife and 2 kids in a car crash last year and went into a deep depression and alcoholism. Does that make them a lesser person than you or I? Absolutely not. I've been wearing this shirt when I travel, and I got to tell you, I've had dozens of people come up to me and say, "Where'd you get that shirt?" And then they start telling me their problems. It's like, I'm not a psychologist, sorry. But what it shows to me is how there's people are craving for others to understand their situations. And oftentimes we hide these battles and things. Our patients have these battles they're dealing. We need to make sure that we treat them with empathy and respect all the time. Thank you for being here. Thank you for all you do for your communities. These are our dogs, Piper and Maverick. No more time for questions.
We have a few online, but
oh, good.
For the online people, I'm going to make Steve sit at the keyboard and answer those online since we're out of time. So
will do.
Want to make sure we get everybody their break. But
okay, great.
Go ahead. Wrap up.
All right. Thank you. Take your break, and I'll be around if you have other questions.